Okay, so any questions or anything from the last time we met? Scant 24 hours ago or something like that, I think. Whatever it was. Lost track of time. Okay, so we're going to continue talk stuff. So here we're going to talk about decontamination. What is decontamination? What do you think of that? It's not detoxification necessarily. Getting rid of the bad stuff. A good way to think of it. Okay, so several types of decontamination we can do for our patients. There's dermal decontamination. Again, it all depends on the route of exposure to some of the stuff. So there's ocular decontamination. There's gastrointestinal. We have the most new agents we'll talk about here for gastrointestinal means, but we'll talk about the other ones as well because, again, that can be pretty important depending on the type of exposure you're dealing with. So again, obviously you want to be careful when dealing with these patients because again, if you're doing like a mass casualty incident or some sort of like biochemical attack or there's some sort of like spill or something like that happens, you want to make sure you don't become a patient yourself, right? So appropriate PPE is always very important. Who has ever like practiced in like a mass like decon sort of event? They're kind of fun, right? So again, you kind of get the tents all set up and have your patients come through and you just bring them down, all kind of fun stuff. It's kind of neat if you ever get to practice with it. If you work in a hospital, at least here in Orange County, we do a yearly sort of county-wide sort of event where everyone kind of gets to practice. We have like high schoolers come in, they get to be our patients, and they usually have like fake like trauma stuff like glass sticking out of their head and all kinds of cool things. And so it's kind of fun to get to practice with it. Typically, you want to make sure you're removing any kind of source for exposure. So for instance, if you have clothes that have been contaminated with a substance, get rid of the clothes, right? So typically we're stripping our patients down, making sure they're not having any continued exposure from a dermal standpoint. Make sure you're flushing all kind of exposed areas. If you're not sure what substance you're dealing with, especially when you have like more lipophilic substances, you need to use soap and water, right? Because again, if you have like olive oil in your hand, just typical water is not going to be enough to get rid of that. You need soap and water to really kind of get rid of that stuff. That's good. A lot of times we'll also use things like diluted bleach solutions. That is also a good way to get rid of some of these substances here. The other thing with bigger patients, especially if they have skin folds, that can be another source for exposure. You need to make sure you really get in there and make sure you flush everything out because you can have things like caustic agents that will kind of embed themselves in those skin folds. You don't look at it, you don't address it, and then all of a sudden you're having this tissue necrosis happening there. So be very careful with those skin folds. As far as ocular decontamination goes, thymus tissue, obviously, the eyes are pretty sensitive to all sorts of different caustic agents and things like that. So one of the big things you want to do is, one, remove any contact lenses, because again, it's hard to kind of flush around that, make sure you're getting rid of all any kind of substance there. And has anyone ever seen a Morgan lens before? Kind of picture here, it's kind of terrifying when you think about it. I don't like things near my eyes anyway, but this is basically a contact lens with like a little tiny tube coming off it that you can actually hook up to an IV line that would have like a normal bag of normal saline attached to it, essentially. And again, you want to be careful with the eyes because like the tonicity of the solution really matters, the pH of the solution matters. So normal saline is going to be really good for helping to flush them out. Now, if they're at home, what can they use? Just tap water, right? So again, just make sure they're flushing is the big thing if they ever get anything in their eyes. So make sure they're definitely flushing. We recommend at least 15 to 30 minutes of irrigation to make sure you're trying to get everything out of the eye there. Because again, our main goal is to try to make sure we get back to a normal pH. And how would you check the pH of the eyes? Just use a normal set of litmus paper or something, a pH strip. You just go ahead and just kind of check in the cul-de-sac there, make sure that the pH has gone back to normal. And so again, you can use normal saline, you can use tap water, it doesn't really matter. Sometimes you have a hard time getting if you don't have like a Morgan lens or something, you can even take like a nasal cannula, hook that up to a bag of saline. You can actually put that over the bridge of the nose, and that way it'll just let it run to gravity and it'll kind of flush out the eyes as well. So it's kind of another route you can use there. But be very careful because I've had cases where a patient gets something, a caustic base in the eye, like liquid plumber. Anyone know what's in liquid plumber usually? Sodium hydroxide usually, right? So it's a pretty nasty base. The thing you have to remember is make sure to go back and check the pH usually 15 or 30 minutes after you're done rinsing out their eyes, because you can have a chance for it to kind of go back to start becoming more basic. They start to complain of more pain, and that can be an issue there, right? So again, and typically you want to go ahead and make sure you're doing a fluorescein stain, look for any kind of abrasions or anything as well when you're kind of done with the flushing aspect. Now, how do you think we could do this with a kid? Like you have a little kid and you're trying to flush their eyes out. How do you think you can? Do you think it's easy, hard? Pretty tough, right? So again, at the home, normally what we recommend is just take a big blanket, just wrap them up like a little burrito, and just kind of jam them under the water and just let it flush. Like they're going to hate you for it, but again, you'd rather them be able to see for the rest of their life than not, right? But we can do that. I remember I had one case where I did my training up in Duval County. Anyone spent a decent amount of time in Duval County. It gets a little rural at the outskirts there, actually anywhere in the county. But you know, little kids, they are playing in the backyard. One of them was, they didn't have any balls to play with, so they were playing with an empty bottle of Drano, and so they're tossing it back and forth, and the bottle cap, of course, comes off. Kid gets it right in his eye, and so we had him come in here. We're trying to play some Morgan lens, but this kid's screaming bloody murder. He's going crazy, won't let us get anything anywhere close to him. We actually ended up having to get some ketamine to like basically just sedate him, get him knocked out, and then we can get in and kind of do what we needed to do. So sometimes you'll need some extra sedation, some chemical restraints to help kind of get these patients in a point where you can actually do what you need to do. But ocular decontamination, very, very important here. Okay, so looking at our GI decontamination, several means that we used to do with this. Glad the GIF kind of worked here. So anyone familiar with, I'm sure I'm not so old that you guys have at least seen Family Guy at some point in your lives, right? Okay, good. Right, so we have several means of GI decontamination. The main goal here is to try to eliminate any further exposure by getting it out of the GI tract as quick as you can. What we're going to find is that inducing emesis is never going to be recommended. And in fact, you can't even find really Ipecac anymore unless it's like in a super diluted homeopathic concentration. Basically, what we had though is Ipecac was really good because it stimulate the chemoreceptor trigger zone to induce vomiting for these patients. Some of the things you have to be careful though is that you know, the type of substance you're dealing with, and the main problem you run into with inducing vomiting is what can that do? What kind of complications could you see with that? Maybe esophageal tears, usually not like an acute case like this. Aspiration. You worry about aspiration, right? So again, whatever substance they might have ingested is probably not going to be nearly as bad in the GI tract as it would be if it got into the lungs. So normally, you like to worry about try to prevent aspiration at all costs. So again, if they have a foreign body, right? So if you try to induce vomiting after a foreign body, if it goes and gets in the airway, it's a lot worse there than it was in the GI tract, right? If they have a caustic substance like an acid or a base, again, if it burns on the way back down, it's going to burn on the way back up, right? So again, these are several things you don't want to use. And the other big thing why we took off Ipecac from the market, because it actually was being abused by bulimic patients. Basically, they're using this to help induce vomiting, so that way they could lose weight. And so they actually noticed that it caused a cardiomyopathy over time. So you'd have these like very thin adolescents who were coming in, but they had these huge, gigantic hearts and basically had CHF the rest of their lives. So because of that, several years ago, it got taken off the market essentially, and the American Academy of Pediatrics that don't use this stuff anymore. And really, we didn't really get a whole lot of return on our investment when we were using this stuff. Even if you were to say take an overdose right now and you give an Ipecac immediately, you'd only get maybe like a 30% amount of that actual substance back out. So really not that great of a drug. But you hear about it a lot. We don't recommend it anymore. If somebody has some stuff laying around the house, tell them not to use it, right? Some other things we may occasionally use, so something like gastric lavage. You guys familiar with gastric lavage? What would that be? Yeah, basically they're going to have a G-tube in, and basically you're going to have this two syringe setup here, and basically you'd be able to instill a large amount of water or normal saline down into the GI tract, and then it has a very large diameter tube there where you can basically pull stuff back out. We don't do this too frequently because there's some considerations you have to consider, where basically you know, substances that are too big for the holes in the side of the tube won't be able to fit through it. A lot of different you know, products are just not going to be able to be absorbed that well. So honestly, we don't do this too frequently, but occasionally you may find that is done on a rare occasion. Honestly, most people don't even know where the lavage kit is in the ER, so we just don't ever really worry about using it too much. The other big thing with this GI decontamination is usually the time frame is within 1 hour. If it's past an hour, the stuff has probably been so far past the stomach, it's not really going to be worth our benefit to give anything. So we do not recommend a lot of the stuff, GI decontamination, past 1 hour. So that's kind of the golden time frame there. You may extend that out to maybe 2 hours if you're doing with like an opioid or an anticholinergic. What do you think that would be? Yeah, slow down the gut motility, exactly. So again, if they have hypoactive bowel sounds after like an opioid overdose or an anticholinergic like antihistamine, hypoactive bowel sounds, I could probably maybe see extending this out by 2 hours. But the other thing is, you know, do we always know the time frame for these overdoses? A lot of times we don't, right? So again, if they were found down for an unknown period of time, like I have no idea when they ingested the stuff, it's not going to be of any benefit to us. Right, so again, you have to be aware of your contraindications. So again, if they're an aspiration risk, if they're not protecting their airway, don't worry about doing this lavage, because again, if they throw up and they aspirate, it's not going to be good for them, right? Again, going along with like corrosive or hydrocarbon ingestion is not going to be beneficial here, and foreign bodies are no good. So again, other things to consider, especially if it was like caustic ingestion, you can potentially have an esophageal perforation if the tube's going down the esophagus and can damage the tissue there. So you want to be careful with this one. Not routinely recommended. However, what we do like to use quite a bit is going to be activated charcoal. Has anyone ever tasted activated charcoal? It actually does not taste bad. It looks very nasty. It's just a kind of dark black substance. However, it is actually pretty sweet. Actually, it's formulated in a very sweet sort of solution with sorbitol. However, it has a very gritty sort of texture to it because, again, this is very much just regular charcoal, just kind of put under a high amount of pressure to try to increase the surface area. And so the goal here is to try to absorb all the medication or whatever substance happens to be by putting it in this very large surface area solution. It kind of absorb it, and then it kind of gets eliminated through the feces, right? So that's kind of the main goal when you're giving charcoal. And so we can use it for several things, but typically it needs to be within that 1 hour time frame, unless there's like an opioid or anticholinergic, and you can do it within 2 hours. But the other thing is again, we do not want them to be an aspiration risk. If they're potentially not protecting their airway, if they're so sedate where they're not really protecting their airway, this is not going to be a good option for them. However, if you have like a typical like peds ingestion, it's potentially blood pressure medication or something like that, they're within an hour. This stuff is great to go ahead and give them, and it will absorb up all that medication, and they'll just kind of poop it right out. So it's good from that standpoint. Again, I won't quiz you specifically on doses, but just kind of have for your reference here. Normally 25, 50 grams is the typical dose. Sometimes what we'll do to try and make it a little bit more palatable for kids is if you can put, say, like a cover over the cup, so that way they can't actually see it, and then we put some like chocolate syrup down the straw. That way it'll kind of mask the taste a little bit. Kind of help them out from that standpoint. But again, very good drug from that standpoint. This is probably the most recommended form of GI decontamination, but the time frame is going to be super important here. If it's more than an hour, or if it's been unknown time frame, we just do not recommend it. So some things that it does not bind though, and this is important to remember as well, because again, if we're making this recommendation, we want to make sure that the charcoal actually binds to it. So things like alcohols, right? So again, if it's ethanol, if it's a radiator fluid, things like that, it's not going to really bind to alcohols very well. They also get absorbed pretty quickly and kind of pass that pylorus to the stomach very quickly as well. So not a lot of benefit there. Heavy metals. So when I say heavy metals, what do you think of? Besides Metallica and Pantera and all that good stuff. Lead, that's a good one, right? So lead would not be absorbed. What are the metals? Mercury would not be bound to it. Iron, like iron products would not be bound to it. Lithium, any kind of metal, right? So you can go down the periodic table. Any of that stuff would not be bound up by charcoal, so this would not be recommended in those cases. Hydrocarbons as well, so things if you had like anything in a hydrocarbon base, like gasoline or like turpentine or things like that, would not also be absorbed by charcoal. That would be no good for it. And then again, contraindications are going to be if they're an aspiration risk, if they have any kind of intestinal obstruction, and if it's a corrosive agent. Again, we don't want to give them anything that might potentially make them throw up, because again, corrosive stuff going down the lungs is going to be no good for them, right? And it's going to burn all the way back up, just the same as it went down. Okay, we can also do whole bowel irrigation, and this is where we're going to use our Golightly, which is polyethylene glycol. You guys were talking about some polyethylene glycol during your presentations. What do we call it then? Yeah, so again, the doses are very different here between Miralax and Golightly. This is typically like what we're going to do for like the bowel cleanouts, like prior to surgery and things like that. They're going to be like in a big like 4-liter sort of container, and again, basically we're going to be using this as an osmotic laxative to basically flush out everything from the GI tract, right? So this is good for things that do not get absorbed by charcoal, things that we cannot get from going from the top of the GI tract. We're just going to flush it all the way through essentially. So heavy metals is good, body packers and stuffers, right? So if you had someone who was maybe crossing the border and they had a bunch of drugs in their GI tract, just go and flush them all out with that. Sustained release products are good too, to try to get rid of those more quickly. And then if you had like concretions, when I say concretions, what do you think that means? Another name could be like a pharmacobezor. You guys ever heard the term bezor before? So bezor is normally just like a big massive lump of something in the GI tract, and so we can see certain substances can kind of form these concretions that kind of just sit there and they slowly absorb the drug. So you can have things like aspirin can do this, potentially iron can do this, several different things. You can even have, you have like vegetable-based products, sort of bezors. You can have hair-based bezors. There's different types of bezors out there, but we're mainly focusing on the drugs here from this standpoint. But that could be another thing to try to again flush things through. And so we have to give this pretty quickly. So you're giving like 500 mLs up to 2 liters an hour. And again, which route are we giving this by? It would be the oral route, but again, most often, people say this stuff tastes like warm sweat. A lot of people don't like to drink 2 liters an hour of anything. that even tastes good. So oftentimes we're having to do this via an NG tube. So you usually have to push this stuff pretty hard. And then our endpoint is usually going to be clear rectal effluent. So making sure they've basically cleared everything out of the GI tract. Once we see that, then we know that, yes, we've probably gotten rid of whatever substances were there, right? Okay, and then again, make sure you're checking your placement when you're doing your NG tube. How can you check for a placement of an NG tube? Oh, you can do X-ray. What's another way you can do it more quickly? Yeah, you can try to push some air through it. If you hear the guts kind of bubbling up some, then that kind of gives you a clue that, yes, it's in the GI tract, right? If you don't hear anything, then it's probably going to be potentially down the lungs. You don't want to put Golightly down the lungs. It's not going to be good for them in any sense of that. Just like charcoal down the lungs, not a great option. In fact, anything down their lungs, not good from our tox standpoint. Just go with that. So anywho, so again, make sure you confirm your placement, because if you're pushing 2 liters of fluid down their lungs an hour, it's not great. Okay, so we'll cover just a couple of different substances here. Acetaminophen I like to cover just because I have a little bit more time here, and it's such a kind of an important thing because again, when you think about like acetaminophen, the big organ toxicity you think of is what? Think about the liver. Anyone know how quickly it happens? Like if I take like a massive amount of acetaminophen right now, am I going to just like keel over and die? Yeah, it's absolutely delayed. And one of the big things we talked about toxidromes, right? So if I overdose on an opioid right now, what would that look like? I'm not going to do it. You guys don't have to worry about me. Respiratory depression, CNS depression, probably pass out on the floor. Right, with acetaminophen, I could look fine for 24, 36, 48 hours, right? I remember I had one patient who, he was very depressed, decided he wanted to go ahead and kill himself, and so he took a huge amount of Tylenol, and again, stuff's cheap, it's easily available, and, he like went to bed and expected not ever to wake up again. Sure enough, woke up the next morning, he's like, I feel pretty good. I guess I must be meant to live or something, So then he goes to the library and he's looking it up and he's like, oh, acetaminophen poisoning. This actually takes like a while to actually kick in. By the time he got to us, it was about 36 hours later. He was completely jaundiced head to toe. His INR was already starting to spike up. He was in bad shape. He ended up surviving ultimately, but acetaminophen can be very, very kind of insidious in that kind of respect. It takes time, and there's no real apparent toxidrome to it. There's nothing you can look at, say like, oh yeah, you look like an acetaminophen overdose patient, unless they come in, they're already so bad that chances are they're not going to do great anyway. So the question is, what is so bad about acetaminophen? Is it the drug itself that's that dangerous? Not really. And normally we can process acetaminophen pretty well. So just to give you an idea of the different kind of metabolism pathways and how this toxicity occurs, is that your liver has the means to detoxify acetaminophen in several different means. So it can do it either just eliminate some of it unchanged with the urine. It can undergo a glucuronide conjugation here, which is one way, or it can go through the sulfation pathway. All of these are non-toxic. You can just eliminate them through the kidneys, no problem, right? Everything's great. However, when I take a whole bunch of acetaminophen, what do you think happens to these pathways here? They get exhausted, they get oversaturated. So essentially, you end up forcing more of this process, more of this metabolism to go through CYP450. And namely, it's this enzyme called 2E1. So CYP2E1 is important here because this will actually lead to this product called NAPQI, or NAPQI. This is the really dangerous component here. This is the thing that's going to cause liver damage. It's going to cause potentially renal damage, all kinds of toxicity here. And so this is the thing we worry about. And this is what gets produced in very large amounts in acetaminophen overdose. And so your body has some means to be able to detoxify it via this glutathione conjugation, but this is also easily oversaturated and exhausted in patients who have overdosed on this stuff. So this is the problem. When you have too much of this being made and not any good way to detoxify, it ends up going and causing a lot of cellular toxicity. Okay, so this is the thing we want to watch out for, and it takes time to produce this because again, the Tylenol is not the problem. It's when it gets metabolized into this NAPQI that it goes and causes some damage here. So it can take quite a while before anything really happens for your patient. So again, once you start to deplete that glutathione concentration, that's when you're going to start to see a lot of issues here. And a typical therapeutic dose of Tylenol, you can use as a good rule of thumb, is like 10 to 15 mg per kilo per dose, right? So again, you can take that 4 to 6 times a day, not really going to run into any issues. And normally, what would you recommend as a max dose for a patient in a day? Yep, probably no more than 4 grams, right? Because then you start to worry about liver stuff. Normally, like a toxic dose here for these patients is like 150 to 200 mg per kilo. So they take a pretty decent amount before they run into issues, or if they're taking kind of super therapeutic amounts like for a long period of time. So sometimes we'll have what we call chronic ingestions, or maybe they're taking like say 5-6 grams a day for several days. Maybe they're having chronic pain issues and they're taking this like for a month. This is where you can also run into some issues here. And so basically, it can cause cellular damage and death, especially in the liver, and also produces a lot of those free radicals. Remember what free radicals like to do? They're very reactive. They interact with oxygen. They're going to go and cause a lot of tissue, protein denaturation. They're going to go through and cause lots of different damage because they are so reactive. And so because of that, can go and have damage in the kidneys, and cause CNS damage, heart damage, all kinds of good stuff. So because of that, like this is what we want to detoxify, and this is where our antidote is going to be really useful here. Anyone know what the antidote is? Or you do? Talked about it in CF briefly. The mucomist or N-acetylcysteine or acetaminophen will be another brand name for it. We'll talk about that in more detail. So again, the reason why some patients might be more predisposed to toxicity here is what we'll see is one, if they have an increased frequency of dosing, if maybe they're taking like every 3 hours, every 2 hours, that could also predispose them to some toxicity here. Chronic alcoholics also tend to be more at risk here as well because one, they already have kind of pre-existing liver damage, but also they have kind of ramped up 2E1 anyway. So they have more of that 2E1, more that's available to metabolize Tylenol into that NAPQI. So that can be a problem. And also some patients may have kind of a glutathione deficiency, or if they're kind of malnourished chronically, things like that can run into some issues. But really chronic alcoholics, chronic people who are dosing themselves super therapeutically too frequently, those tend to be the patients who are kind of the most insidious and will present with some pretty significant liver damage already by the time they're kind of first caught. So what would normally happen after, say, an acute acetaminophen ingestion, so if I just took a whole ton of Tylenol right now, what you expect to see is that for the first 24 hours, probably not a lot. Maybe a little bit of nausea, vomiting, maybe a little bit of diaphoresis, but other than that, really nothing. Most patients are going to be asymptomatic during this time period, which is so important because when you are managing a patient who's presenting for an overdose, what drug level do you always have to get? Acetaminophen. You always have to check an acetaminophen level because there is no toxidrome associated with this. Again, I can look at a patient and tell if they're an opioid overdose. I can give them Narcan and try to wake them up. If they wake up, guess what? It's an opioid. With this one, there's no good way to tell unless I can do a drug level to see if there's any on board. Okay. So anytime you're dealing with an intentional overdose patient, you have to check a Tylenol. Okay. Because if you miss this, 24, 48, and you send them home, and 24 hours later they come back with fulminant hepatic failure, that's a boo-boo on you, right? So again, you don't want to do that. You want to make sure you're checking these patients for Tylenol poisoning. So anyway, if you have a really massive ingestion, maybe they'll present with some maybe decreased level of consciousness, things like that, but rarely do they ever do this. Usually they'll be presenting asymptomatic. The other thing is what's frequently is acetaminophen co-formulated with? Codeine, hydrocodone, oxycodone, right? Those are very common opioids people abuse. So you may be kind of dealing with them from the opioid standpoint first because they show up, they're obtunded. You need to either worry about intubating them or giving them Narcan. Again, you have to consider, hey, there's probably acetaminophen here as well. So it's always going to be part of your assessment when you're managing these patients. 24 hours, nothing's going on. 24 to 36 hours, that's when you're going to start to see the transaminases start to elevate. You're going to start to see ALT, AST start to bump up there. And what we really are worried about is starting to be the PT-INR. Once I start to see that the PT-INR is going up, what does that tell me about the liver? Starting to fail. Why? Not making clotting factors. Absolutely. So again, I can see LFTs, right? That's not necessarily a sign in decreased liver function, even though the name would kind of indicate that. But the PT-INR, once that starts to go up, once I start to see bilirubin go up, lactate go up, I know things are getting pretty bad, right? So really severe ingestions can start to present like this. But the first thing you'll see is usually the LFTs start to rise there, right? So in the stage 2, 24 to 36 hours. The stage 3, this is really the kind of the dangerous phase here, especially if they were not caught early on and did not get any kind of early intervention here. So 72, 96 hours, you're going to start to see jaundice, you can see renal failure, hepatic encephalopathy. It can be pretty bad. So at this point, patients may be at risk for death from hepatic failure, around 3 to 5 days or so after that initial ingestion, right? So this is if they receive no treatment whatsoever or they presented very late. This would be one of those cases where you could potentially see this. And again, you could do things like a liver transplant. However, if someone intentionally overdosed trying to harm themselves, how likely do you think they'll be on the top of that list for hepatic transplant? It's not great, right? Maybe there are some certain circumstances where patients will get a transplant, but it's not very frequent. Okay, so we like to manage them medically first, but most patients do not go to get a transplant. So if they recover, they'll enter the stage 4. It's kind of the recovery phase, and it may take weeks to months before their LFTs actually start to get back down to normal. But one of the things we'll look for is, one, we want to see the PT-INR be totally normal. That shows that the liver's functioning again. If the LFTs are still rising, but they're still high, but they're trending down, that's a good sign as well, and that's okay for us. So we can send the patient home. LFTs are still in the hundreds. That's okay, because if they were in the tens of thousands before and now they're down to the hundreds, that's a pretty good change from that standpoint. So we can go ahead and send them on their way, right? So is falling LFTs always a good sign? I'm asking the question, so it must be, there's probably a bad sign that could be. So at some point, I've had patients who are so severely poisoned from this stuff that they will have their LFTs rise, and then eventually they start to drop back down. You think, oh, things are going great. INR is still going up. At some point, the liver runs out of enzymes to start to release. So at that point, that's a very bad sign if you start to see that. So again, you want to make sure PT-INR is coming down on its own. You want to make sure lactate's going down. You see LFT starting to drop as well. That's all good things to show you that the patient's starting to recover on their own. That's a good thing there. So again, history oftentimes is going to be unreliable in a lot of cases unless it's like maybe a chronic ingestion where they're kind of just been self-medicating. They may be more likely to be a little bit more honest, but if it's an intentional ingestion, just assume they're kind of lying to you until proven otherwise. And so always check an acetaminophen level. Okay. You can also go by, and we'll do this at the poison center. We'll kind of base what their dose was and decide whether or not they need to go in. So if it's an adult and they ingested more than 7.5 grams, that's an automatic yes, we're going to send you in to get evaluated. It's a cut point. For kids, and we get calls like this all the time where parents say, oh my gosh, my kid, just drank an entire bottle of Tylenol. We'll do calculations to figure out whether or not we need to send them in. It's usually like 150, 200 milligrams per kilo. That's when we'll send kids in to get evaluated. So how do we evaluate whether or not someone actually needs the antidote? Has anyone ever seen the Rumac Matthew nomogram? It's a very popular nomogram, I will tell you, especially if you work in emergency medicine. You might use this nomogram quite a bit. I met Dr. Rumac several times at the tox conferences. He's kind of like a local tox celebrity sort of thing. Dr. Matthew's dead, but Dr. Rumac is still alive, and so he's a very nice old gentleman, wears a bow tie, very, very sweet. But he was a pediatrician basically. Back in the day, back in like the 70s or 80s, whenever they designed this, they basically had these Tylenol ingestions. We're trying to figure out what is the level that you would actually need to treat with the antidote at. And so what they did was they divides this nomogram where basically you can determine based on when the ingestion occurred and what their Tylenol level is, are they at risk for developing hepatotoxicity? If they are, then you go ahead and treat with the antidote, and if not, then you don't have to worry about it. So basically what you see is that at 4 hours, notice it starts here at 4 hours. So if you have a patient who ingested their Tylenol 30 minutes ago, you can't really use a nomogram yet. You need to wait until they get to about 4 hours. And you're thinking, well, why would I want to wait? We got time, and I'll talk about why that is in a second, but you have up to 8 hours before you really need to start treating these patients. So we'll see why that is. But basically, you're starting at 4 hours, a level of 150 is going to be considered potentially toxic to the liver. If you pass this line, then we go ahead and treat at this point. So anything 150 or higher, and keep in mind this is like an acute ingestion. This is if I took one big dose 4 hours from now and it was above 150 at 4 hours, I would go ahead and treat that patient. Okay. If I came back and it was 4 hours and the level came back 75, guess what? I don't have to treat that. Level's low enough, it's very unlikely they would develop hepatic toxicity. Okay. Again, remember this is only good for acute single ingestions. This isn't good for someone who's kind of chronically dosing themselves every 2 or 3 hours and their LFT is already rising and things like that. That's not going to be good for them. This is good for acute single ingestion. But you can do this at any point. So again, if I go, I have the patient really present sort of late and they show up 8 hours later, I can go and I can check this out and say, okay, well, if they're at 75 milligrams or mics per ml, okay, yes, I need to go ahead and treat that point. But if they're below that, they're good to go. Okay, does it kind of make sense? So you can just plot it out based on the level and what the time frame is. Yes, ma'am.
If they're low enough to where they don't have to be treated, is there something bad that would happen if they did get the antidote?
You would not. We'll talk about the antidote in a second, but yeah, there's really not any serious consequences to.
It's just so you don't.
Yeah, but if you think about, say you had someone who, typically like in the ER setting, do you want to keep patients around for a long time or you want to kind of get them out? You want to circulate patients through pretty quick, right? So if I have a patient who shows up and say they're 4 hours out from an ingestion and it comes back and it's lower than the treatment line, that's potentially someone I can medically clear and get sent out to psych and I can get a new patient in, right? However, if they come back and they're in that treatment line, we're going to see the time frame, how long the treatment actually takes. That's an automatic admission, right? So they're going to have to come in and get treated for that. And so again, we always like to try to minimize costs wherever we can. That's one of the big things the poison centers are good for, is to try to limit how many people you have to treat, how many people go to the ER in the first place, and try to minimize that cost. So if we can figure out that they're below that treatment, they're very unlikely to develop toxicity. You say, okay, we feel very confident they're below this level, go ahead and send them home. You don't have to worry about it, right? Or send them wherever they're going to go, because again, if they're trying to harm themselves and probably need to go to psych. But yeah, this is one of those things where we can kind of give a good idea. Do we need to give the antidote or do we not? And this is one of the big things that helps us. So does that make sense? How this works? You just plot it out. If it's below any of the treatment lines, then you don't have to treat. If it's above this bottom line here, now I notice this kind of higher line right here. This is actually what they use in the UK. But us being in the US, we decided to be a little bit more conservative, so we dropped it by 25%. So that's just how it is. So you'll see always 2 lines on there, but if you're above either of the lines, then you go ahead and treat at that point. Okay. So again, when you're monitoring these patients, it's good to look at their acetaminophen. You're looking at their LFTs, PTINR, especially if they have any kind of rises in LFTs, is where you want to go ahead and monitor that. If it was someone who was like an acute overdose and they came in, I wouldn't get a PTINR immediately, but if I saw their LFTs already elevated, I would probably go ahead and add that on at that point just to see where they're at. And the BMP can be useful to get a good sense of kind of where they're at from the electrolyte standpoint, from kidney standpoint, etc. So management, obviously, if you can get them within an hour, we can use activated charcoal if it's clinically appropriate. Also, if it was like a hydrocodone acetaminophen ingestion or oxycodone acetaminophen, we could also just go ahead and use use that 2-hour rule for using the charcoal, because again, the hydrocodone or oxycodone should be slowing down the bowel motility, right? So they're hypoactive bowel sounds, I can go ahead and consider giving charcoal up to 2 hours at that point. Now again, if they're having any kind of hypoglycemia, because again, you can see that with this really severe liver damage, because again, where does glucose normally get produced? In the liver, right? So you can see hypoglycemia. Obviously, we replace that with dextrose if you need to. Having any kind of coagulopathy, you can consider giving like vitamin K. But again, if the liver's not really at a point where it's really kind of functional enough to produce new clotting factors, it's not going to be super useful. And occasionally we'll give blood products like FFP or something to kind of replace those factors, but not normally needed in a lot of cases. And don't remember these criteria, but there's certain criteria we use for transplant to determine whether they need to use transplant or not. Very rare that we need to do this. Usually the antidote's going to be good enough for most of these patients. So again, how do we correct this issue? Well, we try to see if we can try to detoxify that NAPQ and try to help our liver metabolize more of that Tylenol into kind of the safe sort of metabolites. We're going to have our antidote here, which this NAC stands for N-acetylcysteine. This is where it's going to be helpful for us. We're going to see it helps with this glutathione conjugation, so that is going to help directly detoxify that NAPQ. It's going to help with helping to produce a sulfation pathway again and help us to get rid of that extra Tylenol. So again, here. It's called N-acetylcysteine. We mentioned it also can be used as a mucolytic. So if you ever see it being inhaled, it's not being used for Tylenol overdose, but being used as a mucolytic there. And so we find, I mentioned it, we have time. We have up to 8 hours before we need to treat these patients after an acute ingestion. And so it's 100% effective if we give it within 8 hours. So even if a patient shows up, say 2 hours, 3 hours post-ingestion, I need to wait an hour to get that acetaminophen level back, that's okay. I have time to wait for those patients. Because as long as I get the antidote within an 8-hour period, we're good to go. Now afterwards, is it still effective? Sure, but we just don't have we can't say it's 100% effective at preventing a liver transplant or preventing hepatic failure at that point. So again, very good. We'll even give this drug very, very late because it actually helps with some free radical scavenging. It helps to kind of work as an antioxidant in some cases and still produces some good effects here. So again, N-acetylcysteine is our antidote for acetaminophen poisoning. So there's two varieties. We have an IV form called acetadote, and there's an oral form called mucomist. So if you see mucomist, that's referring to as the oral form. And I mentioned it has a lot of sulfur in it because you saw that it actually helps to donate to that sulfation pathway. What do you think it smells like? Rotten eggs, right? And again, I've been desensitized to the smell of it. So now it just smells like regular eggs to me, which makes me worry about if I'm making eggs at the house. Like, am I really a good judge of egg character anymore? Not really. I would not call myself an excellent judge of character. Yeah. Anywho, right, so again, it smells very bad. So imagine a patient trying to swallow this. Things are going to go very well. Not really, right? So again, a lot of nausea, vomiting associated with this. Again, this is another thing where if you can try to mask it as best as we can, we'll try to put it like in a citrusy sort of drink, like orange juice or something that helps to try to mask that a little bit. But a lot of times we're kind of moving more towards doing more IV treatment nowadays. It's a little more costly. And the one thing you have to worry about with IV administration is there is some risk for anaphylactic reaction. However, it's pretty rare for the most part. So most people are now starting to get more IV use. However, sometimes people want to be a little punitive and maybe give oral mucomist. I don't necessarily agree with that, but some people are like, well, they're going to be, messing up my ER and, taking a bunch of Tylenol. They're going to drink oral. Gosh darn it. Not really a good way to treat patients, but so usually IV is the way to go in most cases. So just know there's, oh, do you have a question?
Yeah, does the acetadote not have sulfur in it?
It still will have the sulfur, but when it's in the IV bag, you can't smell it, right? So again, it would still theoretically smell just as bad as the oral form.
No, just like, what do you do if they have a sulfur?
So Sulfur is different from sulfa, right? So you want to make sure you keep those separate in your mind. So a sulfa is kind of a side structure on a molecule, right? So like sulfamethoxyl has a sulfa moiety on there, and that is what they have a reaction to. Just sulfur itself, they don't really have a reaction to, because again, our body contains sulfur all the time, right? So it's just a natural chemical that, or natural molecule that our body has all the time. Again, we have a sulfation pathway in our liver that functions 24/7, right? So again, we're just helping that sulfation pathway work even better at that point. So again, no cross-reactivity there, but thank you. That's a very good question. So a couple different ways we can do it. The IV formulation you see here is a 21-hour protocol, so usually you can get away with a little bit shorter treatment time. The old protocol, the oral one, was actually 72 hours, right? So again, you're already committing your patient to staying in the hospital, about 3 days or so, if you decide to use an oral regimen. There's some ways we can actually shorten it nowadays, but you don't have to worry about that. Just know there's a couple different protocols that are available. Usually the IV one's a little bit shorter. You can get away with 21 hours of therapy generally. So, and you're going to find, so imagine if you had someone like a really massive overdose and, I treated for that whole 21-hour period. What do you think I want to monitor for? When do you think I can kind of feel confident I can go ahead and stop that acetaminophen at that time? What lab test would I want to look at? So LFTs, yeah, clotting studies, I want to look at PTINR. PTINR should be normal, right? If it's elevated, it probably shows them still have damage going on. Need to continue that mucomist. What else? Acetaminophen should be what? Should be negative, actually. So yeah, so without any acetaminophen around, they're still potentially producing some of that NAPQI. So acetaminophen needs to be negative, PTINR needs to be normal, and what else? What other thing do I monitor? LFTs, right? LFTs should be coming down. They don't have to be completely normal. They should be kind of getting close to it, or starting to head in that trend, right? And again, a lot of times what we're looking at is going to be trends and levels to make sure they're kind of heading in the right direction. If not, then we need to consider giving more mucomist at that point. But just know this is the antidote. There's IV PO forms available, and there's different protocols that you need to kind of look up. Make sure you're looking at that dosing there, because it is different between the two regimens. Okay, so any questions on that? Again, something you'll deal with more common than you might think. Again, always make sure you're checking your Tylenol levels. Now, again, what if you had someone who shows up, say, for instance, you had a history, they had a Lortab overdose with hydrocodone, acetaminophen. They show up pretty late. We have no idea how long they were down for. EMS brings them in, and their LT is already rising, but their Tylenol level is negative. Kind of rule out Tylenol toxicity at that point. Some have a lot of providers question me about, but they say, well, how can it be acetaminophen toxic if they have no acetaminophen in the blood? Well, if they've already metabolized that into the toxic metabolite, then they can still have a problem with that. So again, there's still some cases where I'll recommend giving mucomist, even if they don't have a measurable Tylenol level, right? If they're still showing evidence of hepatic injury, I'm going to go ahead and do it anyway. So again, there's some a lot of different cases, a lot of shades of gray there, but again, just know kind of the basics for that, and then it'll be good for your purposes. Okay. We'll cover more substances in the CMS lecture that I'm working on. We'll have in a couple weeks for you guys. But I want to cover a couple of things you're going to run into Florida that you may not run into elsewhere. Who plans to practice in Florida when they graduate? Yeah, a decent number of people. As you're getting out, I don't blame you. That's what it is. It's pretty hot here. However, we'll cover some envenomations you might run into with some frequency here being in Florida. So what do you think of when you think of envenomations? Snakes. So you gotta worry about the snakes, right? What do you think are some of the common snakes we run into here in Florida? Coral snakes. Actually, Florida is the king in the U.S. for eastern coral snake bites. Water moccasins, good. Why do you call them water moccasins? I actually don't know that. What's another name for water moccasins? Cottonmouth. Why do you call them cottonmouth? They have the big white mouth, right? Looks like cotton in their mouth. What else do we have? Eastern diamondbacks, copperheads, and pygmy rattlers. Those are the big ones we're going to talk about here. Now, there's big two major delineations here between the different snakes we're going to. And have you guys covered snakes at all yet? You might hear about it in some other places, but basically what you're going to find, there's two big classifications here of snakes we're going to be dealing with. We have the pit vipers, which are going to be our water moccasins, are going to be our rattlesnakes, and there's going to be the coral snakes, okay? The reason why we delineate them is because their venoms are very, very different from one another, okay? We'll talk about those toxicities are in just a second, but these are the main snakes you're going to run into. When do you think most of the bites actually occur? Yeah, so, yeah, summertime, right? Why summer? Snakes are cold-blooded, right? So when it's warm outside, they're more active. Guess what also is happening during summertime? People are going, yeah, they're out swimming, or they're, kids are at home from, on summer break, So lots of reasons why this occurs. Now, being here in Florida, being so warm, guess what? We get snake bites all year round, basically. I've seen, rattlesnake bites happen up through November, December, no problem. So any time of the year is a potential here. So who do you think are going to be the frequent victims of a snake bite? Guys, that is very sexist. I do not appreciate being typecasted. Yeah, it is guys. Guys are. What about children? Do you think it's always male children? No, the gender distribution is pretty equal between kids. Because again, why do kids get bit by snakes? They're interested, they're curious, they see something colorful, they're going to pick it up, and then all of a sudden it bites them, right? But for adults, typically skews more males, right? So again, what are some things that can influence these adult sort of bites? Alcohol. So I like to go off the 7 T's. 7 T's are my main ways to tell who might be at risk for snake bites. Testicles or testosterone, right? Tequila, ethanol, right? Ethanol is usually involved here. Usually trucks, trailers, a little bit more rural sort of setting here. It's just this is the way it is. Toothless, tattoos. And usually if you use the tattoo to tooth ratio, that usually gives you, the higher that is, the more likely. And then I usually say tatas because usually someone's trying to impress a lady and they say, hey, come look at this. Not good. Listen, this is after I've dealt with hundreds of snake bites. I know what I'm talking about, right? Usually it starts off with hold my beer, and then or people trying to get selfies with the snake. Not a great idea. Not good. Okay. So those are the main types of people you're going to see getting bit by these snakes here, and with handlers and collectors, right? So again, one of the things in Florida is it's very lax from a exotic reptiles license sort of standpoint. So if I can get a license to have an eastern diamondback, I can have a license to hold any kind of reptile I want. So whether it be a black mamba, whether it be an Egyptian cobra, anything that I want, I can have access to, right? It seems a little silly, and I agree that it probably is pretty silly. But we have handlers more often than you think, and I always love getting those phone calls, like in the middle of the night, someone calling from a random ER, and they say, "Hey, we got this Egyptian cobra bite. What do we do?" And it's like, okay, I'm going to look that up because last time I checked, we are not in Egypt, and we do not have cobras here naturally. So yes, it can be a bit of a challenge there. We'll talk about that in just a minute here. So here's an example of pygmy rattlesnakes. What do you notice about the identification here? How could you identify a poisonous snake versus a non-poisonous snake here in Florida? Triangle-shaped head, good. The eyes, what about the eyes? Has to do with their pupils. They should have elliptical-shaped pupils. They almost look like cat eyes, right? If it has round pupils, and then again, this is only going to be for the pit vipers. We'll talk about the coral snakes a little bit later, but this is going to be for the pit vipers. And I apologize for anyone who has a herpophobia, I guess would be the term. I don't know. If you're afraid of snakes, my wife is terribly afraid of snakes, so she hates this stuff. However, so if you have elliptical pupils, that is a good sign as a pit viper. Okay. Anything else? They have giant hypodermic needles sticking out of their mouth. That could be a good sign. So the coloring can be kind of tough. Certainly, if they have a big diamond pattern, it's probably a diamondback, right? So that could be one thing. But sometimes you'll find some snakes will kind of masquerade around. So coloring pattern, I don't go off specifically for pit vipers. But anything else? Well, you know something on the snake's tail. A big rat. If there's a big rattle, probably a rattlesnake, right? Does it always have to be there? Not necessarily. They've recently shed, then they may not actually have the rattle present. So if you don't hear it, does not mean it's not a rattlesnake. So that can be another kind of misnomer with that one. What do you kind of notice? It's hard to tell in this picture, but why do we call them pit vipers? Yeah, these little pits kind of located next to their nostrils, and basically those are heat-sensing organs. That's how they can detect food and things like that. Very good at detecting changes in temperature. So they can look for food with that, and that's why they call pit vipers. Anything else you can think of? Those are the main ones. We also have another means. You can look at the anal plates of the snake. Again, this is a little bit esoteric. However, it does come in handy every once in a while. Basically, if it's a single row of anal plates, I'll show you a picture a little bit later, then you know it's a poisonous pit viper. Okay. Why do you think that might be important to know? How do you normally kill a snake? Decapitate it, right? So you normally cut the head off. So if I only have someone bringing the body of the snake, then I need to be able to identify it. There's no rattle there, and the color's not really specific. It's going to be hard to tell. I can actually look at the anal plates of the snake and actually be able to determine the difference, right? Again, you don't have to look at a snake's butt to figure out if it's poisonous or not, but again. Most pharmacists would not know this, but you can call the Poison Center. Anyone remember the phone number? 1-800-222-1222. Fantastic. Yes, call the Poison Center. They can help you out with this stuff. The nice thing as well is, like, you know, what does everyone have in their pocket right now? A phone, which normally phones have a camera on it. Guess what? We don't need people to bring in these nasty snakes into the ER. They can take pictures of it, and that's going to be fine for the most part, right? Because again, if you decapitate a snake, is that snake still dangerous? The head can still have those kind of reflex arcs and bite, up to an hour or so after it's been decapitated. So you do have to be careful with that occasionally, right? So there's an example of. Here is a copperhead. Now, as far as this is actually two copperheads together. Two heads are better than one, as I say. So if you're looking at kind of the grand scheme of toxicity, which ones do you think are going to be the worst here? Obviously, the bigger they are, probably the worse they're going to be. Yeah, the scariest looking ones. So typically, the eastern diamondbacks are going to be one of the worst from a venom standpoint. Pygmy rattlesnakes are also going to be pretty bad. And then kind of in descending order, you're going to have like the water moccasins and then the copperheads. A lot of people won't even treat copperheads from an anti-venom standpoint because they're pretty wimpy for the most part. You see these more like in the panhandle. You don't see a ton of them down here, but certainly you'll still see them occasionally. Like in Georgia, they get a lot more copperhead bites, and they're pretty wimpy for the most part. So, and then we also have the cottonmouths or water moccasins. Notice that's why they get that cottonmouth name there. It looks like they have a bunch of white stuff in their mouth. And even like when they're younger, they can actually kind of look like pygmy rattlesnakes. That's why the coloring can be kind of difficult with those guys. And where do you think you're going to find these? Yeah, by lakes, streams, any kind of body of water, you're more likely to find those. Which again, during summertime, oh yes, you might find them out here, I suppose. We had an issue when we first opened up Nemours. Is anyone around this area before like Medical City was like developed? What was it all? It was like swamp, like cow pastures and stuff like that. So when you built like brand new hospitals, guess what? All the animals got to go somewhere. So we ended up having a bunch of rattlesnakes and stuff that would kind of like hang out on our patio and by the cafeteria. Yeah, animal displacement, not a fun thing. But. And then here's an example of an eastern diamondback. So if you see that diamondback pattern, yes, you should feel pretty comfortable thinking it's dangerous. Let me just stay away from it, right? But yeah, notice that big triangle-shaped head. That's another good thing you can kind of tell whether or not it's going to be a venomous snake. So I mentioned the heat sensing pits there. They're going to have those hinge fangs that come out. I mentioned the anal plates use that single row is what we're kind of looking for there. Pupils should be elliptical. You can kind of see that with this little guy right here. And then they'll may or may not have the rattle. So again, just use that as kind of plus or minus if you see it's good. Now, as far as looking at the characteristics of the bite themselves, typically you want to kind of figure out how many strikes there actually were. Now, usually when you're looking at these bites, you're kind of assessing for fang marks, right? Now, typically how many do you expect to see? 2, could there be more or less? Yeah, because again, remember things like their fangs are kind of like shark's teeth where they're going to pop off and they can be replaced over time. So you may see 3 if you have a new one coming in. You may only see 1. So again, just keep in mind, you may not always see 2. Now you need to be thinking about the venom status here. So when I say dry bite, what do you think that means? Yeah, so they got bit, but they didn't actually have any venom injected here. About 25%, 20 to 25% of your bites are going to be dry bites. Doesn't mean not everyone that gets bit by a rattlesnake does not need to have antivenom. That's where we can do some monitoring for dry bites. Because again, antivenom is not without its negative consequences. It's a very expensive medication. We like to hold off on giving this if we can help it. But things like that you need to consider. Things that may influence whether it's a dry bite or not could be the season. Normally like during the summer months, they tend to be more active, tend to be producing more venom. If they've eaten recently, do you think they have more or less venom? Less, right? Because they just used it on their last meal, so they might be less likely to have that available to you. And then looking at the size of the snake, obviously a bigger snake, more venom is going to be producing there. And then also look at the location of the bite. Where do you think most bites occur here in Florida? Yeah, I normally think the hands, right? Because again, people are usually kind of trying to pick them up and look at them. It's like kids, oftentimes are going to be the hands. We'll see feet occasionally if you are walking around and like you step on them. That could be one thing. But I just had a lady that was bitten by a coral snake the other day. She was actually in her garden, reaching into some bushes and got bit. So again, the hands are a big one around here, at least in the U.S. But not always the fault of the patient, but a lot of times it is. So again, just some more diagrams to kind of show you how you can identify a poisonous snake versus a harmless one. Again, this is going to be different when we talk about the coral snakes in just a few minutes here, so kind of keep that in mind. Again, look at the single row of anal plates there. Okay, so what do you think about the toxicity? What do you think is going to happen with these patients? How does rattlesnake venom actually work? Clots of blood, also thins the blood. It's almost like a disseminated intravascular coagulopathy. It uses up a lot of your clotting factors and fibrinogen and things like that. But you're going to see a lot of swelling. You're going to see a lot of ecchymosis around the site especially. And you're going to see a lot of pain associated with this, right? So what do you think your vital signs are going to be? Probably elevated, right? I just got bit by a freaking snake. Like I'm in a lot of pain and I'm pretty freaked out, right? So again, they're going to be usually elevated, hypertensive, tachycardic typically, and you can see a lot of damage being done right at the local site of where the bite was. So a lot of swelling, a lot of ecchymosis, and that's actually going to be some of the things we're looking for in determining whether or not we need to treat these patients. Questions on the first half class today? I don't know. All right, so continuing on with our Crotalidae. That's actually another name for the family here, pit vipers. We call them Crotalidae. We talk about coral snakes. We'll talk about the Elapidae family of snakes there. But with the Crotalidae, again, there's lots of different components of the venom itself. And again, it's meant to kill small animals and things like that. But it does cause a lot of direct tissue damage. You're going to see a lot of tissue necrosis associated with this, a lot of swelling, a lot of edema. You're also going to find that this causes a coagulopathy. So I mentioned that, there's procoagulants, there's anticoagulants, so typically what you would expect to see, and again, this goes directly into what monitoring parameters you're going to be looking at. On the CBC, what might you expect to see? So if it's going to be acting like almost like a DIC sort of picture, decreased platelets, absolutely. So you see thrombocytopenia, it'd be one of the big things we're monitoring for, okay? How about your clotting studies? Increase, yeah, typically increase, right? So PTINR, PTT are two of the big things we look for, right? So again, those should typically be increased. And then we also look at our fibrinogen, right? Fibrinogen you'd expect to be also decreased, right? So just like in DIC, it kind of looks very similar to that. So typically, you're going to find decreased fibrinogen, decreased platelets, and increased PTINR and PTT. Right, those are the things we're looking for typically. That's going to be more the systemic sort of effects you're going to expect to see after one of these bites. Okay. Now, does everyone get systemic toxicity? Not necessarily. It depends on how much venom was injected. It depends on how well it's being absorbed. Whether it was more of a subcutaneous sort of injection versus IM versus IV in some rare cases. It all kind of depends. But really, the local effects where you're expecting to see most commonly, and then you're going to expect to see those kind of systemic effects for more kind of severe envenomations. Okay, but you're still going to be monitoring for everything the same regardless. One of the questions I always ask my patients as well is I say, hey, do you know how big the snake was? And they're like, oh, I don't really know how big it was. And then I ask them, well, do you know why they measure snakes in inches? And they say, because they got no feet. I almost got kicked out of an exam room one time because I made such a joke that bad. Anywho, so as I mentioned, local manifestations, you're going to expect to see a lot of painful swelling. This stuff gets very, very painful. They can have paresthesias developing due to this, a lot of ecchymosis and blistering, tissue necrosis, and then occasionally you might even see things like rhabdomyolysis develop. There's a specific type of snake called a canebrake rattlesnake or a timber rattlesnake. We don't see those bites too frequently here, but they can be very, very severe in those cases. Typically, your rattlesnakes are going to be the most sort of venomous, the most kind of dangerous sort of venom, followed by your moderate moccasins, followed by your copperheads. Again, some people don't even treat copperhead bites. They tend to only cause some local, swelling and inflammation, but not a lot of total systemic effects like you would see with a rattlesnake. Now, systemic reactions, you can certainly see a lot of fear, pain, anxiety associated with this. People get very freaked out when they have these bites that happen here. Typically, you're not going to find a lot of other effects in this. There's not a lot of like neuro sort of effects unless you were maybe out west in like say like New Mexico or Arizona. You see like a Mojave rattlesnake that actually has some neurotoxins to it, which looks like a coral snake, which we'll talk about later. But the hematologic toxicity is the biggest thing we're going to be looking for, as we kind of mentioned what we're going to be monitoring with CBC, fibrinogen, and coags. So typically what we're going to do is, the initial first aid, and again, what we typically hear are the calls from the patients at the poison centers initially when they get bite and say, hey, what do I do? So what should you do as far as first aid goes for a snake bite? What does kind of common wisdom tell you to do? Wash it off. Wash it off with soap and water is a good idea. Absolutely. We actually do not recommend empiric antibiotics for these. As long as you clean them well, then you don't have to worry about antibiotics for those patients. Very few get infected. Anything else? What do you think? Tetanus? Yeah, you definitely want to think about a tetanus. But what about the patient before they get to the hospital? They're just out. You actually do not want to put a tourniquet on, but you might think, let me put a tourniquet on because that'll help keep the venom locally. Yeah, actually don't want to do that. Well, no, because a lot of patients think like, oh crap, I need to keep this venom from getting, if it hits my heart, I die. Like this is like what movies and TV has kind of taught us inappropriately. But we actually do not recommend a tourniquet because actually what you can see is that when people are freaked out, they put a tourniquet on. Is it like nice and light sort of tourniquet? it's super tight, right? They're going to cut off all blood flow to their arm or limb, essentially, and it's going to cause more tissue damage, right? You want oxygen, you want to get into that tissue because it's going to be damaged anyway by that venom. So do not recommend a tourniquet for those patients. And you also do not recommend sucking the venom out because, again, it does not prove very effective. However, you want to test your friend's loyalty to see how good of a friend they are. You try to have them suck it out for you. See who your real buddies are. Just kidding. Don't do that. You can try cutting it out, but none of that's going to work, right? The best thing you can do is tell the patient to get a set of car keys. Huh? Yeah, to get to the hospital, right? You don't actually rub the car keys on the bite. It doesn't actually do anything. I had one student think that, and I was like, they're like, how does that work? And I was like, no. They should drive themselves to the hospital. What they should do. Anyway. So, again, when they get there, you want to assess them for their tetanus status. Again, when should I update their tetanus? Every 10 years, or if they don't know, if this is like, Jim Bob from out back in the woods got bit by a rattlesnake, guess what? He probably doesn't know when his last tetanus was, if he ever had a tetanus in the first place. Let's go ahead and give him a dose of Tdap. Go ahead and update him. And then you want to check for allergies. So specifically, we want to see if they've ever been bitten by a snake before. We want to see if they've ever received antivenom before. Because, again, this is going to be proteins we're injecting in these patients. There could be a chance they've been hypersensitized. And, again, a good chance, if you've been bitten by a snake one time, do you think they correct their behavior and lead a new life to keep them from ever being bitten again? Unlikely, right? So, again, typically they're going to kind of continue these bad behaviors. And so they may be at risk for getting bit by a snake again. So, and then what can I get for pain and anxiety? What do you think? Yeah, benzos would be good for they're really kind of freaked out and anxious. I can give them some benzos like lorazepam or midazolam. What else? Opioids. What can I give them? Morphine's fine. Anything else? Dilaudid, fentanyl, any of those are totally fine. What would you not want to give them? NSAIDs. Why not? Yeah, they're already at risk for bleeding anyway, so why give them an NSAID? We're not going to do that, right? So those are things to consider there. Opioids are fine. Benzos are totally fine. They help get that pain under control. Very, very painful sort of bites here. So things you want to do, you want to do these circumferential measurements. You want to be measuring kind of around the limb to see how large the diameter of the actual limb is becoming. And again, these can get very, very swollen. They become 2-3 times the size of the unaffected limb, no problem. Again, if you're doing things like measuring blood pressure, which arm do you want to do it from? Probably the unaffected limb, right? If you're doing measuring your labs, guess what? You probably want to do it from the unaffected limb. I've seen some cases where people are not doing that appropriately. But one of the things you want to do is make sure that you're measuring in between 2 different lines. So what I mean by that is, essentially, if I had, say the patient's arm here, and again, I apologize for my bad handwriting or bad drawing. So let's say they're a Simpson character, okay, and they got bit by a snake right here. You basically want to measure with some tape, and so what you can do is actually measure between 2 different lines. Why do you think I want to measure between these 2 lines? So I'm looking to see if the diameter is increasing, but what happens if like one nurse comes along, they measure right here, versus when another nurse comes along and measures right here? What do you think the size difference is? Yeah, there's inter-rater unreliability in those cases, right? So if I measure off the tape, and again, usually most yards will have measuring tape you can use. If I pull it between these 2 lines each time, then I can make sure I get accurate measurements. Because this is going to be one of the things that dictates whether or not we're going to give antivenom. Is based on, is the swelling increasing at a significant enough rate that I want to go ahead and give the antivenom. So that's one thing to consider there. I mentioned as far as labs go, you want to go ahead and get PT, INR, PTT, fibrinogen platelets. Those are the big things for monitoring there. And then we'll typically do like an initial measurement, and we'll do it 6 hours later. Okay. One of the questions is, if it appears to be a dry bite, there's no kind of swelling going on, the coags are fine. How long do I need to watch the patient for? Right? How long do you think? You have an idea? Yeah, so probably like 8 to 12 hours. If they're somewhere in that range and there's no significant swelling going on, we'll talk about what that means in a second, and no hematologic toxicity, you can go ahead and consider that a dry bite, and you can send them on home. They're unlikely to have any kind of bad outcomes after that point. We'll see it's going to be very different when we're dealing with coral snakes in just a few minutes here. But now there's very rare instances. In fact, if I ever have a snake bite patient, I immediately say, get your surgeons, get your orthopedic surgeons away from my patient. The common thought before is when you have a limb that gets so swollen, what do you think you're worried about? Compartment syndrome, right? The best thing for that swelling is going to be more antivenom. We used to do things like fasciotomies to try to relieve that pressure. The only thing it does is maim your patient, right? It's only going to lead to more scarring and things like that. The best thing you can do is give more antivenom to this patient. So occasionally we'll do like a digitotomy if we have a really severely swollen finger and we're worried about compartment syndrome, but rarely is that ever needed. Typically, we can just give more antivenom here. And then occasionally we may need blood products, but it's pretty rare for the most part. Typically more antivenom is going to help to kind of relieve that need. Because again, if I give more clotting factors, you know, say if I give FFP to a patient and they still have circulating venom, they can interact with it. Guess what? It's going to inactivate that too. So it's not going to be the best thing for us. So antivenom is really the best treatment for these patients. Okay, so again, imagine if you had a patient here getting like a fasciotomy. It helps relieve the pressure in the immediate case, but really compartment syndrome is not a huge issue we see with these patients very frequently. Okay, so the antivenom that we use is called Crofab. Anyone ever heard Crofab before? Right, so think Crotalidae, FAB, right? So that's basically where the name is coming from. So it's going to be ovine-derived product, which means it comes from what animal? Sheep, absolutely. So because it's a sheep protein, basically we hyperimmunize a sheep against several different types of Crotalidae. So Western Diamondbacks, Eastern Diamondbacks, Mojave, and Cottonmouths. You don't need to memorize this list specifically. Just know that we have several different snakes, and notice that we can use this for other types of snakes. We can use this for copperheads. We can use this for you know, pygmy rattlesnakes. That's okay because within this family of snakes, there's enough homology in the venom that it will have some cross-reactivity. You'll be able to neutralize those no problem. Now, the indications we're going to use this for, and does anyone think this is cheap, expensive? Super expensive, like thousands of dollars for a full course of treatment for these patients. You know, we've used dozens and dozens of vials of the stuff, and it can be very, very expensive very quickly, especially with like an Eastern Diamondback. It's pretty bad. But basically what our indications are going to be, there's significant swelling, which usually my cut point for that is if it crosses a major joint. So for instance, they got bit in the hand and it crosses in past the wrist, I consider that significant swelling, right? And again, it all goes with a time frame. If it's been 30 minutes and their arm is already like doubled up in size, yeah, it's a pretty clear indication. But if it's been, you know, 10 hours and it's just now starting to get a little bit of swelling in the hand, maybe starting to maybe creep past the wrist, I'm much less likely to treat at that point. So again, it's going to be something with the more you see them, the more you get comfortable dealing with these patients and deciding. But significant progression of swelling is one thing there. And if we see any coagulopathy, so and even if it's a trend, right? So even if your platelets start at 400 and then it drops to 200, is 200 an abnormal platelet? No, but that's a pretty significant trend, right? I still consider that a coagulopathy that I'd want to at least follow and potentially treat for. And if there's any kind of hemodynamic compromise, anything like that, we'd go ahead and treat as well. Okay, so those are our main indications. Good to know when we would want to go ahead and treat these sort of bites. So typically what our dose is going to be is we're going to do between 4 and 6 vials. And so this is going to be very much practitioner dependent. You kind of gauge based on the patient's presentation and history how much you want to give. And notice here, there's no PEDS dosing. Why do you think there's no PEDS dosing? Because the snake's not looking at you going like, oh, you're looking about 6 years old, I'm going to inject this much venom, right? The snake doesn't really care. So the same amount of venom gets injected regardless. So it's going to be more based on how severely envenomated the patient is, how progressive the swelling is, how severe the coagulopathy is going to be. And so we'll decide between 4 and 6 vials. We'll basically put that into some NS and then infuse that over an hour or so. And then after that point, we'll go ahead and draw coags again to kind of see where the patient's heading, see if there's any kind of significant trends going at that point. Now, the thing here with Crofab is that this is actually an FAB fragment. So basically, if you imagine like a normal, and again, this is not going to be completely accurate, but imagine you have an antibody here. So again, you have like the FC portion, the FAB portions here. Notice if you inject an entire antibody, that tends to be pretty immunogenic, right? It means it's going to be more likely to cause an anaphylactic reaction. So what these people did is they actually come along and they actually cleave off part of the FC portion. It makes it so it's much less likely to cause a reaction, which is beneficial to your patients. However, the half-life is pretty severely limited, so we have to give repeated dosing to the patient. So this is where we do this maintenance dosing. We'll do like 2 vials for every 6 hours for 3 doses. And then usually at that point, after 24 hours, we'll kind of monitor them, see how they do without any antivenom. And if they stay good, they don't do any, no further progression of swelling, no coagulopathy, and then they're good to go home at that point. But I was going to go with that. Anyway, so that's the typical dosing. Usually 24 hours worth is what we'll give for those patients, and we'll monitor them for about 24 hours post that point there. Now, again, if you give antivenom, it's not going to reverse the swelling that's already occurred. It's only going to prevent further progression, right? So I'm not going to give it to them all of a sudden their arms are going to shrink back down. Doesn't really happen that way. It takes some time, usually days to weeks, before that really gets back down to normal. So, as I mentioned right here, and then you may need to treat anaphylaxis. Patients who've had repeated doses may be more likely to have a reaction. With Crofab specifically, I've never had any issues with anaphylactic reactions, but just keep that in the back of your mind. You may need to treat with that. And then typically we'll educate them to follow up with their PCP for further coags, just to make sure there's no delayed coagulopathy. And we'll, again, make sure that they let their healthcare providers know that they've received antivenom before in case they ever get bit by a snake again. What's serum sickness? Anyone know what that is? It's It's like a delayed hypersensitivity you can see when you have like antibody injection. Basically, it's kind of like fever-like or flu-like symptoms, nice some myalgias and fever. They can just take some Tylenol. That's no reason to come back to the hospital for us. But then for the next, say probably a few days to a week or so, I also recommend not going in for any like elective procedures. If there are kids at home, make sure they're not really roughhousing too hard, because again, they're more likely to bleed and bruise from that standpoint. So I would recommend they just take it easy for a couple of days. Okay, so any questions on the pit vipers?
What did you say happened with fibrinogen?
Fibrinogen typically decreases.
Decreases.
Yep. If you have an undetectable fibrinogen, not a good sign. No bueno. Okay. Moving on, next we have the coral snakes. These guys are fun. So how do you identify a coral snake? Red on yellow, kill a fellow. Not a friendly fellow, no. Red on yellow, kill a fellow. Red on black, friend of Jack. Venom black is another one. I say red on yellow, run the hell away. Red on black, run the hell away, and you're safe. That's what I usually tell patients. They always don't listen to me. The other thing, you need to make sure you're looking at the body of the snake, because you'll actually find on either end it starts to kind of lose that pattern. So again, you see red on yellow. Yes, that is absolutely a coral snake, but on either end here, you notice that it start to lose that a little bit. Normally they'll have like a black head as well. And notice they're not going to have big giant hypodermic needle fangs. They're not going to have those elliptical pupils. They look almost like a non-venomous snake. And this actually gets confused pretty easily with like a scarlet king snake. Notice here, this is going to have the red on black, so this will be a non-venomous snake. So pretty easily you can look at it, pretty brightly colored to know whether or not it's going to be venomous. This only goes for North American coral snakes. If you went to other countries, the coloring pattern does not hold up. So if you go to South America, if you go to Asia, anywhere, this does not hold up. You need to be careful with that. So just North American coral snakes. Now, typically, these guys are going to be pretty docile. They're pretty reclusive, if anything. So when do you think people get bit? It's almost entirely when people are picking them up, right? So again, this is not going to be something, they're not going to be nearly as bad when you step on them, because like a pit viper, they can get you a real quick bite and you're envenomated. These guys, they don't really have those big giant fangs. They have these kind of rear hinge sort of fangs where they have to actually sit there and chew on you. So they have to sit there and macerate before they'll actually break the skin to actually inject the venom. So typically what you hear is they actually have to, if you have a history where they pull the snake off, that is a good sign they may have been envenomated, right? If it just gives a quick little bite and falls off, it's probably not going to be an envenomation. They didn't really have time to break the skin and inject that venom, okay? So my favorite story of a coral snake is this elderly gentleman who is out in the backwoods of Georgia, got life flighted to our hospital for a coral snake bite. And so he ended up getting the anti-venom, and then he goes to the ICU for monitoring. And so we go in the morning doing our rounds, and we go see the guy. I'm talking to him, and I'm saying, well, what happened to you? What was the history here? He's like, well, I was walking through the woods, and I found this colorful little snake, and I picked him up, and the little sucker bit me. I said, okay, so did he hold on? Did you have to pull him off? Like, nope, it fell right off. And I said, okay, well, that doesn't sound like you had an envenomation. And I'll talk about the symptoms a little bit, but he's having like ptosis and weakness and all very classic signs of envenomation. And so I said, well, that doesn't sound like an envenomation. What happened? He's like, well, the second time I picked him up, the little guy sucker just bit me, then it fell right off. And I was like, well, that doesn't sound like it either. It's like the third time, though, when I picked him up, he held on. I had to yank him off. They say it sounds like Velcro when you pull it off. To give you a little bit more kind of a visual picture there. I was like, okay, so the snake gave you 3 tries, and you failed each time. And he's like, well, I guess that's how it goes. And I'm like, no, it's not how it goes. You just not pick up snakes. So anyway, so that was one of my favorite stories, just because it was like, okay, yes, the snake does have to hold on in most cases. It's not going to give you like a little quick nip, because they usually are going to be more, these are like defensive strikes. So it's usually not trying to envenomate you. No coral snake is looking at you like you're its next dinner, right? So. The main difference here in the venom for these elapidae, these coral snakes, is going to be that it's a neurotoxin, right? So again, you don't see any hematologic toxicity associated with it. It's primarily neurotoxic, and it actually kind of has this curare-like effect where it works very similar to a lot of the paralytics that we actually have that we use for like intubation or use for surgery. And so basically what you're going to see initially is going to be maybe some local, a little bit of local swelling, but really nothing severe like you see with the pit viper. They're going to start to develop some numbness. They're going to start having some paresthesias, and that's going to show you that yes, there's probably something going on here as far as an envenomation. Eventually, you're going to get these more kind of systemic sort of effects where you're going to start to see like ptosis. You're going to start to see weakness, and you're going to start to see. Notice the big problem they run into is this diaphragmatic paralysis, right? That's the thing where they can develop respiratory failure if not caught early. And in fact, how many deaths do you think we see due to coral snake bites here a year in Florida? Zero, because we have good treatment, right? So even if you got no antivenom, we can intubate you and keep you on the vent. And actually, this is where I did my research during my fellowship, and the average time, if someone needed to be intubated for a coral snake bite, average time they were on the vent was like 8 days. So it's a decent amount of time they're going to be intubated here. Again, you worry about things like pneumonia, secondary to that, and whatnot. But you know, with early treatment, they're not going to have any issues here. We maybe have like 3 to 5 deaths due to rattlesnakes a year in the U.S., but you know, not a ton. So again, there's not a lot of mortality associated with these snake bites. Anyway, but these bites can be pretty, seem pretty unimpressive at first, but they do need to be monitored for some time, because we'll have patients that will develop manifestations 18 hours after the initial bite, and if they're not caught early and treated, that's when they can progress onto respiratory failure. That's really the big thing we're trying to avoid there. So it's hard to distinguish those dry bites. So I mentioned for pit vipers, you can monitor for them 8-12 hours. If they look good, no swelling, no coagulopathy, send them home. These guys need to go to the ICU because they need to be monitored for at least 24 hours post that bite. Okay, so again, it seems a little conservative, but it's one of those things where when you catch it, you need to go ahead and treat it early. Otherwise, again, you worry about having to intubate those patients. So, mentioned you can develop things like slurred speech, paresthesias, this dysphagia, stridor. That's the thing we're really worried about developing there into the respiratory paralysis. And just know that the effects can be pretty prolonged if they do develop. And notice that the antivenom is not going to reverse anything. It's only going to prevent it from getting worse. Right? Once it's already there on the receptors, it's not going to be able to really reverse it. And again, the paralysis is completely reversible. It just may need to take some time there. So again, I mentioned need to be monitored for at least 24 hours from the time they come to the ER. And again, the same first aid recommendations are going to be made for the pit vipers as for the coral snakes. You need to make sure not to like cut or suck or tourniquet or anything like that. It's not going to be beneficial. Just go ahead and wash it off soap and water, get your tetanus up to date, and send them into make sure they get to the ER, right? Now, this one, we're going to find that the antivenom we're giving here is much more likely to cause allergies. So again, ask if they've ever been bitten by a snake before, if they've ever received antivenom before, because it can be really important. We're talking about monitoring for anaphylaxis here. And again, very frequent neuro checks. We're going to be doing this every 15 minutes initially, and once it kind of stabilizes out, we'll kind of continue maybe doing every hour or so for that 24-hour period. And so usually they need to be in the ICU just because they need that kind of close nursing care. It's not necessarily they need really intensive treatment necessarily. Okay, so the antivenom we have is kind of an interesting story, at least if you're interested in tox stuff. We have this equine North American coral snake antivenom. Now, this actually is not being produced anymore. They're working on kind of getting production back up, but the company that was making it actually got the production shut down. And so actually, if you go and get a coral snake bite today and go into the hospital, you're going to be receiving expired drug product. And you think, well, it's expired. How can they give that? The FDA has to go in every single year and retest this stuff. There's only like 1 or 2 lots that we have available to us, and make sure that it still is within appropriate range of activity. If it is, then we say, okay, we're going to extend it another year, and we can go ahead and use that drug. So again, we have to be very, very judicious with this use, because if we just give it to anyone who has a history of any kind of coral snake exposure, we're going to run out of this stuff. And again, this is really only a Florida problem. You really don't find this issue really elsewhere. So again, these companies don't have a huge incentive to like kind of rush to get back to making this stuff, because maybe we have like 50 bites a year, but it's not like a huge money maker for these patients, right? Or for these companies here. So anyway, so it's an equine antibody, which means coming from a horse, of course, right? And so we're going to find that it's a full antibody, much more likely to have allergic reactions and full anaphylaxis. People have really bad reactions to this, a lot more likely to have serum sickness as well. So again, almost everyone's almost guaranteed to have serum sickness. But basically, you can try to do like a little skin test where you do like a 1 to 10 dilution, do like a little subdermal bleb, and see if they have a wheal and flare. If they do, guess what? You still got to treat them, right? Because you don't want to leave them intubated for that long. And so oftentimes we'll make sure we have anaphylaxis meds at the bedside, which includes what? Epi, Benadryl, steroid. Yeah, so I'd probably go ahead and give them Benadryl and steroids, and then I have the epi at the bedside ready to go in case they get hypotensive or have any kind of airway reactions there. So that's one thing to really kind of watch out for. And typically we'll just do 3 to 5 vials based on kind of time frame, how severe they're being, or how severe their symptoms are. And with this one, the half-life's a lot longer, so you only have to give the one-time dose. So again, I had a call about this the other day when I was on call, and basically they'd say, hey, we had this like 50-some-odd-year-old lady. She was She's out gardening, reaching into the bushes, and got bit by a coral snake. And so my first question is, did the snake hold on? And the doc says, no, snake didn't hold on. But it's, she's here in the ER. What do you think we should do? And so unfortunately, because we can't definitively say she wasn't envenomated, we'll say, well, let's go ahead and hold off. Let's not give the antivenom, but let's go ahead and monitor for 24 hours. So recommended admission. But the guy was like, well, we only have 1 vial of antivenom here, but our sister hospital has a couple of vials up the road. What do you think we should do? I said, okay, well, at least get a courier to come transfer the vials over, so that way you just have it available in case she does have a reaction, and then there you go. The only other alternative would have been to potentially transport the patient, which is a lot more expensive. So it's easier to get a courier in a lot of those cases and move the med around. But yeah, so it's pretty straightforward treatment, but just remember anaphylaxis is very likely to occur because it's an equine antibody. Okay, so any questions on snakes? So again, if you ever have a case where you have like a cobra bite or any kind of exotic sort of snake, what do you think we do? Say tough luck, see you next time. We go to the zoo. Yeah, so we actually, every zoo is mandated to have antivenom for every snake that it carries, right? So if they have cobras there, they need to have cobra antivenom. And where do you think they get cobra antivenom from? Well, they immunize horses usually with cobra venom, and that's how they get the antivenom, right? So basically, we have to go and get like African cobra antivenom, right? And so we've actually had to use this a few times. We had one repeat customer who I probably learned more from this guy coming in than any other patient because I probably saw him 5 or 6 times. Treated him for multiple rattlesnake bites, Mexican can-teal, which is like a Mexican pit viper, monocelic cobra, Egyptian cobra, what else? Lots of different stuff, right? This guy was a handler, and I guess not a very good handler because he came to come see us. Black mamba as well is the other big one that we had with him. But so in those cases, if you ever do have a bite like that, we basically contact the zoo, and the poison centers have a system where we can actually go through and look to see what every zoo has available, and we can go to them and say, hey, we need this antivenom, and so they're not FDA-approved products, but they have special licenses they have set up so they can actually carry this stuff, and we'll go and we'll have the patient sign a boatload of releases saying, hey, if I die from receiving this, it's not on you because we're using non-FDA-approved products. We ended up giving it several times. We had to use it for this patient. But yeah, so if you ever are curious, we go to the zoo, and that's where we get our antivenom from. Okay, so any questions on snakes? Black mamba bites are pretty cool. Don't get bit by black mamba, but there's some cool stories out there. Anyway, okay, so moving on, caterpillars. Are caterpillars a problem? We're just talking about snakes, deadly snakes. Caterpillars can be pretty bad. Maybe not from a mortality sort of standpoint. We have a couple of different indigenous varieties here. Anyone have a caterpillar phobia? Probably not. These guys seem pretty innocuous for the most part. We have a nice little saddleback, nice little lime green saddle he's riding around with. We have these pus caterpillars, Io moth, and we have the hag caterpillar, which I think is very rude to call something a hag, but it is what it is. So what do you think the problem with caterpillars are? The hairs. The hairs are the problem here. So the hairs can be very, very painful, in fact. And so when they, get your hair stuck in the skin, it's one of those things where the pain is very much out of proportion to what the actual injury looks like. And so I've had these kids, and I remember this one case we had where it was like maybe like a 15, 16-year-old kid was coming in, and this kid was crying in the ER. He was just sitting there in the waiting room. He was just sitting there crying in so much pain. And the mom's like, I don't know what his problem is. I don't see nothing wrong with this thing. Skin looks totally fine. The kid's like crying. They got this little pus caterpillar in a little Ziploc baggie. And, it took like 2 rounds of Dilaudid just to get this kid's pain under control. Like, this stuff is very, very severe. And finally, after the second dose of Dilaudid, the kid's finally like, finally relax a little bit. Mom's like, I guess maybe it was in a little bit of pain there. So don't always discount your kids. Sometimes they're acting in case. But basically, these little tiny hairs are going to have some toxins associated with that, cause a lot of both mechanical, by kind of piercing through the skin, but also these toxins cause a lot of local damage there to the tissue. And again, it looks pretty innocuous for the most part, but very, very, very painful. So the question is, and the clinical term for this is going to be lepidopterism, in case you ever want to impress your friends. But basically, you can see a little bit of swelling, maybe some erythema, but the pain's the really biggest thing here. Even some patients are so painful, will induce vomiting in some patients, so you may see that. And occasionally, you may have like some eye and throat exposure, but again, rarely you'd see that. Mostly going to be dermal exposure for the most part. Rarely, maybe some allergic reactions, but mostly just the pain we're dealing with. Now, the question is, how do you get rid of the hairs? There's a case where industrial strength medical grade duct tape is going to come into play here. Duct tape is actually one of the best things you can use for this stuff. So basically decontamination is the biggest thing. We want to eliminate further exposure. So you can go ahead and take some duct tape and go ahead and pull the hairs off using any tape will work, but duct tape we like to use. And make sure you go ahead and wash it with soap and water. That's really the biggest thing there. You can also get like some antihistamines if there's any kind of local kind of inflammation happening, but really NSAIDs potentially, maybe like some IV Toradols would be good for them. And the opioids are needed quite frequently. So I mentioned, a couple doses of Dilaudid was needed just to get that kid under some modicum of pain control there. And then typically, usually good after that, send them on home, maybe with some antihistamines, you're generally good to go. So that's really the main thing to worry about with caterpillars. And next we have spider envenomations. So a lot of people come in complaining of spider bites. They normally say, what bit them? What type of spider bit them? A brown recluse. They always say a brown recluse bit me. What do they usually actually present with? Usually an abscess. Usually the abscess is caused by what? Well, it could be IV drugs, but usually it's going to be MRSA. So I like to say it's not the brown recluse, but it's actually the MRSA spider. There's actually a special kind of spider that goes around sneaking around, giving all these people butt abscesses. Not really, right? So everyone usually says they got bit by a brown recluse. Guess what? Brown recluses are not really indigenous to Florida, as we'll find out. So a little bit of a misnomer there. Anywho, now most spiders are venomous because, again, that's how they get their food. However, most of them are not able to really penetrate human skin. Okay, there's a few that can, though, and so we'll talk about those. So two main types we're going to see are going to be the Lactrodectus mactans, or the black widow. Okay, and then we're going to have the brown recluse, otherwise known as a fiddleback spider. And these are going to be the two main kind of venomous spiders we're going to talk about that can envenomate people. Okay, the ones we need to more worry about in Florida are going to be the black widows. How do you identify a black widow? Kind of looks like Scarlett Johansson a little bit, right? Just kidding. No. And typically, is it the male or females that are more dangerous? It's the females. Finally, we get back for those females who are calling all the snake bite patients guys, huh? Just kidding. No, yeah, usually it's the females. The guys are too small to really pierce the skin, but the female black widows are the problem here. Now, there's also like brown widows and red widows and different varieties. So just know they're not all have to be black. But how do you identify it typically? Yeah, the big red hourglass. So if you see that, typically it's going to be a black widow. Okay, and then we mentioned these can be called the fiddleback spiders. So if you look really close here, you kind of see this little fiddle sort of shape or violin sort of shape on the back. That's how you can kind of tell a brown recluse. So anyway, a lot of times these envenomations are difficult to ascertain because, unless you actually see the spider, it's hard to really say it was an actual spider bite. And I mentioned most people are going to come in with skin infections and say, it was a brown recluse that bit me. It probably wasn't. It's probably just you probably didn't clean very well and I got an abscess, right? So usually MRSA is going to be the thing here. So because of that, and again, brown recluses are not super common in Florida. However, you may find some hitchhikers. It's important to be able to recognize when you actually have an envenomation versus not. So the Lactrodectus mactans, or the black widows, we'll talk about here first. Normally you're going to find things like the black widows, but the red widows, which is going to signify or shown here as one you're going to see occasionally. Normally you find these like in around garbage cans and little areas where they kind of form these kind of erratic webs. But the females are the ones you really got to worry about. Question is, what type of envenomation do they cause? Has anyone ever seen like a black widow bite or heard about one? Has really significant muscle cramping. So again, these are very, very painful. Again, these are kind of painful out of proportion to what the actual wound looks like. Because typically you may see two little piercing marks, but other than that, you really don't see much. But the patients are going to be, very much a lot of pain, a lot of muscle cramping that can happen with that. And actually on a milligram per milligram basis, black widow venom is way worse than pit viper venom. However, what's the average size of a black widow versus a snake? Pretty small. They can't really inject a whole lot, right? So typically you're going to see a lot of kind of local effects, and it's due to this alpha lactotoxin that does this. But basically it tries to open up these kind of non-specific cation channels and allow chloride to flow in. And we know that when chloride goes into skeletal muscle cells, what happens? They contract, right? Because remember, the calcium flows in, opens up that sarcoplasmic reticulum, more calcium flows out, and boom, actomycin bind up, and then you have muscle contractions. That's where you see a lot of cramping associated with this. You can also do things like release acetylcholine and norepinephrine, but the muscle contraction is the biggest. And so what you can see, usually around 30 minutes to 2 hours after a bite or so, a lot of cramping, a lot of fasciculations associated with this. Usually that's what kind of prompts them to go into the ER in the first place. Some cases, especially in the extremes of age, so I've seen one infant who actually got bit by a black widow that was very severe. They developed very severe hypertension, and that can actually be potentially fatal. Infants typically do not handle hypertension as well as like adults would do. So this is going to be one thing to watch out for sure. But really, the other big thing is going to be pain. They can have actually a regional diaphoresis around the side of the bite, so they'll just be sweating on one area and nowhere else, which is kind of interesting, I thought. But those are the big things you're going to be looking out for. As far as treatment goes, typically ABCs, make sure they're stabilized first, do appropriate wound care, update their tetanus if they need it, and then we'll see that analgesia is going to be needed here. Most likely, you're going to need IV opioids for the pain associated with this. For the muscle cramping, you can also, what could we use from like an IV sort of muscle relaxing sort of standpoint? Any ideas? So like IV benzos are good here as well, right? So you can use like lorazepam or midazolam. Those are really good to help kind of relax those muscles. So those can be utilized as well. Some people try using IV calcium. It tends to have some transient effect, but not great. So again, I would stick with the opioids, stick with the benzos for the most part. And then there is an antivenom available, but we don't use it very frequently. The only time I've ever seen it used was in that infant I mentioned who was very hypertensive. We gave this, we gave 1 vial against an equine antibody, so we had to worry about reactions there. But I went ahead and helped resolve the blood pressure very, very quickly, which is great. So we really only use it for the very old, the very young, or potentially pregnant patients there. Other than that, though, usually you can send them home with a script for something like a muscle relaxant, like some Flexeril or something. Generally, are good to go for the most part. Here's a non-venomous pig. Anyone's curious? Anyway, then next we'll have the brown recluse. So again, the fiddleback spider is another name here. They're not indigenous to Florida. However, you may find like isolated nests due to some hitchhikers. So if you're like hiking out in Georgia or somewhere, you may see them kind of being brought back as a hitchhiker there. So again, they tend to be pretty reclusive by nature. That's how they got their name, right? And so they're not really going out there to bite people and give them abscesses everywhere. But you can find that some of the manifestations can be kind of look a little similar, as we'll see here in a minute. So what happens here is they have this loxoscelism that they cause here, and basically they have this toxin called sphingomyelinase D. And what it does is it causes a lot of tissue necrosis to occur here, and they have what they call this kind of red, white, and blue lesion that develops. Or basically have this kind of blue necrotic core, this kind of area of like kind of blanched white skin around that, and then this red area of erythema. And it tends to spread pretty significantly. So if you have a true bite, like you really can't miss a brown recluse bite when you actually see it. So when you see that, it's going to be pretty nasty. And there's not a whole lot we can do from the wound care standpoint. Certainly, you can. People have tried to excise it before. Doesn't really work because then that extra sphingomyelinase just kind of continues partitioning out from that border there. Some people tried things like dapsone. Doesn't really work that well. Hyperbaric oxygen, not great. The only thing you really do is just treat supportively, make sure it doesn't get infected for the most part. Some patients, especially the very young ones, may be at risk for hemolysis, which I've seen a few case reports of like exchange transfusion, but very rare you would actually have a severe envenomation like that. Really, the biggest thing is just good wound care for those patients. So again, make sure to keep the testing up to date. Wound care is important there. And again, dapsone's a drug we don't use too frequently, but maybe used to help kind of reduce the severity of that ulcer there. And no antivenom for this one. So we do have an antivenom for black widows, but nothing for the brown recluses. Okay. Are you guys okay if I cut it here? Well. It's okay. Hopefully, caught it up here. By the way, that was no. It's good. All right. So, any questions on that before I let you guys go? We'll finish up marine venomations and move on. We'll probably do like nephro or whatever we do next. It's loaded.
Thank you.
Okay. I'll see you guys next week. All right. Any questions from last time? Anyone experience any toxicology over the weekend? It's just the time when it happens, like Friday night, Saturday night. No random snake bites or anything. Snake bite the drink. There's also that to consider. Anyone know what's in that? It's like it's usually like cider and harp mixed together. So not bad. Anywho, a little early Tuesday morning for that sort of thing though. Alright, so we're talking about marine envenomations, and this is not referring to the military, right? They're not super poisonous typically, but right. So we're talking about things in the water. Some this is important because again we're in Florida, and guess what we're kind of surrounded by? Water, right? So again we're gonna have lots of, and again depending on where you work at. Right here we're a little bit landlocked, so certainly you might see some stuff like lakes and streams and whatnot. However, the more important things are going to be kind of found out in the oceans there. So the first kind of big group we'll talk about here are going to be the Cnidaria, and so this is where we're going to see a lot of our jellyfishes and things like that. Lots of different species of these, and again, a lot of this can be kind of dependent on which part of the ocean you're dealing with. We'll talk about some things that are mainly kind of a problem in Australia, but that stuff can migrate, right? So sometimes you can find some of the more dangerous things around here in these waters. When do you think these envenomations typically occur? Yeah, much more often in the summertime, right? When it's warmer, people are out there and potentially being exposed. So basically, these species have what they call a nidate, which is going to be these kind of hollow barbed threaded with venom, right? So again, they'll have these nematocysts where when something comes along that triggers off it firing, you can imagine why it hurts so bad, because they have these nice little barbed things going into your skin. They have some venom within them that will be released, and so that's what's mainly causing a lot of the issues. So has anyone been stung by a jellyfish potentially? How did it feel? Not great, right? So again, probably hurt pretty bad. A lot of kind of local inflammatory sort of reactions going on, a lot of itching, a lot of redness, some swelling, things like that. But it's pretty painful for the most part. Now, and this is actually kind of important here because you're going to find that the things that trigger these discharges, right? Because a jellyfish isn't really smart enough to look at you and be like, oh, I'm going to go sting this person. Typically, it's going to be much more of a kind of reactionary sort of thing. And so if they have changes like in pressure or say like osmotic changes or chemicals, this can trigger a firing. So it's important because, again, they're normally sitting there in seawater. So if we kind of put it into a different sort of environment, that's more likely to set it up to fire. And so that'll be important. We're talking about decontamination and how we're going to be able to treat these. So there's a couple different varieties here we'll be dealing with. There's also the cubozoa, which aren't actually like true jellyfish, but they actually find the greatest morbidity and mortality with these sorts of envenomations. This is where you see like the box jellyfish, and there's also the irukandji jellyfish, and these are going to be the ones that are most associated with death. We'll talk about some of the issues you can find with those a little bit later. These are typically the more dangerous ones you think off, like being off the coast of Australia, because again, Australia is kind of more dangerous, most dangerous place in the whole wide world, right? Typically, but the oceans again are no kind of exception to that. But however, there are some rare cases where you might actually find these off the coast of Florida potentially. So there's also the hydrozoa. This is probably the most common thing you're going to find here in Florida. So these are going to be the Portuguese man-o-war, or like the blue bottle jellyfish. And so these are actually not true jellyfish. They're actually these colonies of different cells kind of put together, and so they can be very, very painful when they sting. And you may find, they tend to like wash up on shore and things like that. So if you ever kind of like walked up to that kind of nightmare scene where you see like jellyfish just kind of littering the beach, yeah, I was like, oh, I'm definitely not going to the beach today. Whatever happened to these guys, no one happened to me. But they can be kind of dangerous, and their tentacles can actually be pretty long. And that's usually where a lot of the nematocysts are going to be lying, are going to be there on the tentacles. We also have the true jellyfish, things like the sea nettle and the lion's mane, and then we also have things like anemones, which kind of still fit in the same category. Usually they're going to be living among like reefs and whatnot, and so you can normally see like your little clown jelly or your clownfish that can kind of live within there. Anyone fan of Finding Nemo? I get to watch a lot of that. Finding Dory's on Netflix, so we get to watch a lot of that. So so anemones are kind of within the same group here, and again, they'll have the same sort of stinging nematocyst present. So their venom is pretty wide ranging. They have several different kind of chemicals that are present here. So you can see things like dermonecrosis, myonecrosis that can occur with this. So definitely some damage to the cells. You can actually find some of these provide very severe cardiovascular effects. So you can see some very severe hypotension, tachycardia associated with these, and a lot of them end up kind of blocking nerve conduction. So in some cases, paralysis might actually be a thing you may see with this. And again, we'll talk about kind of the most dangerous ones, and then the ones you're going to see more commonly, in your day-to-day practice. But we'll also talk about this irukandji jellyfish causing this catecholamine release. And when I say catecholamines, I'm referring to norepinephrine, epinephrine. What do you think that would lead to? Tachycardia, diaphoresis. Yeah, palpation, but also what do your blood pressure do? Tachycardia, or I'm sorry, hypertension, right? So you can see people can stroke out potentially, especially if they're kind of already at risk for that. So this can be pretty severe when you see these irukandji stings. And again, how often do you think we actually have the jellyfish present to make a good identification? Or how good am I, do you think, at identifying jellyfish? I look at it like, oh, it looks like a jellyfish. Like, that's kind of the extent of it. However, based on the signs and symptoms, we can kind of link it back to a specific sort of toxidrome, if you will, and kind of think what it could have been. Now, again, looking at the more common things you're going to run into, the clinical manifestations of these Cnidaria species, basically you're going to find that a lot of these things are mainly going to cause kind of local effects, not a ton of systemic stuff you're expecting to see. However, the box jellyfish especially can cause very, very severe pain. A lot of times, again, it's out of proportion to what the actual sting may look like. You may see a little bit of erythema, a little bit of swelling, but again, it's going to be very, very painful for the patient. And normally you can expect to see these kind of erythematous linear rashes. So again, that kind of goes back to where the tentacles are actually lying on the skin. And that kind of gives you a good sign of probably what you're dealing with in most cases. Some patients, when they get more sort of systemic effects, they get a lot of nausea, vomiting associated with this, maybe some muscle spasms, and headache typically. But again, most patients are just going to have that kind of local reactions more often than not. So looking at the box jellyfish, this is where you can find some big issues because, again, where are these people getting stung at? Not necessarily on the body, but what location? Well, they're in the water, right? So again, some of these things, especially like the box jellyfish, kind of goes back to why it's so deadly potentially. Because again, you're going to have the potential for things like syncope, paralysis that can occur actually there in the water. So if you have someone who is a good swimmer and all of a sudden they just kind of go down out of nowhere, it could be actually linked back to one of these things. And so in places like Australia, they'll have things like nets that are there on like public beaches and stuff to keep a lot of the more nasty critters out. However, the box jellyfish are pretty small; they can actually get through in a lot of cases and still sting people. But and then if you were to get them out of the water, you have also the potential to run some more kind of long-standing issues like pulmonary edema, renal failure, hemolysis. So again, very nasty sort of venom associated with these pretty tiny jellyfish there. Again, most patients can't make it ashore, and so they end up kind of dying out there in the water, or if hopefully someone can see them and maybe they can get rescued. And then children typically tend to be a little bit more vulnerable and than adults would be. Because again, the jellyfish isn't looking at someone and be like, well, you're a kid, I'm going to sting a little bit less for you than the adults, right? Same for the snakes. For the ear conjugate, there's also, again, this is kind of linked back to that catecholamine release you can see with this. So you can see a lot of tachycardia, palpitations, headache. You may not be able to see the diaphoresis because, again, if they're in the water, they're going to be wet anyway. But maybe once you dry them off, they may be still pretty diaphoretic there. And you also have this kind of neat little impending sense of doom. I'm sure you guys mostly have that on Monday, Wednesday, Friday mornings, probably around 8:25 or so. However, take that feeling and link it back to a jellyfish, and you can imagine what that would feel like. And again, also things like severe back spasms, a lot of muscle activation happening with this. That could be another thing you would see with those type of jellyfish. Okay, so the Portuguese man-o-war, those are the ones we're going to see very commonly here off the coast in Florida. Again, a lot of severe pain associated with that. You can see some skin necrosis, some bullae that'll form. And then less likely, but still possible, you can see some systemic effects here. So you may see things like excessive kind of salivation, lacrimation sort of thing, almost kind of like a cholinergic sort of toxidrome. It's pretty mild for the most part, but you can see things like nasal discharge, lacrimation, etc. And in some very, very severe cases, maybe if you had a very small patient or someone who had a very severe exposure, you can see potential for things like renal failure, shock, death. So not common, but it has been reported before. You guys heard of sea bather's eruption before? So this is another pretty common kind of mild complaint you may see with some patients. So this is actually something where if you have people who are wearing the same swimsuit from day to day without washing them out, this could be something that can happen at the beach. And so basically you have these larvae that will actually be kind of picked up by the bathing suit. And then when you put them on the next day, they actually start to kind of hatch out essentially, and can cause a lot of local inflammation, a lot of local kind of reactions there. And so you see this kind of pruritic papular eruption, and typically it's around wherever their bathing suit was. So again, if it's around the waistband, or if it's around like the bikini sort of area, you can if you see that, that's typically going to be that sea bather's eruption is what they talk about. And especially with that history of kind of re-wearing bathing suits would be something you might expect to see. And again, typically it'll be lasting around 2 weeks or less in those instances, but it's pretty uncomfortable for the patient. We definitely recommend a lot of antihistamines and potentially topical corticosteroids potentially, but other than that, it's pretty mild and self-limited. Okay, so as far as management goes, and what's the classic sort of urban legend on what to do if you're stung with a jellyfish? You pee on it. Do you want to necessarily pee on that stuff? Again, I say it's an urban legend, so probably actually no. Peeing on something is very rarely going to be the answer. Again, you can test to see how good of a friend you have. They say, will you pee on me? And they say yes, and then You may need to have some follow-up conversations, is all I'm saying, okay? So what you can actually find is some pretty variable responses here. In some cases, vinegar, it was originally thought to be something that could actually help to inhibit nematocyst discharge, but depending on the species you're dealing with, you're going to find that it actually is not going to be super useful, because in some it's going to actually increase the discharge. Because we mentioned things like changes in osmolarity, things like changes in pH, all these different sort of things can help to trigger that firing to occur, right? So the main thing you want to be looking at, especially from a first aid standpoint, is when the patient comes out of the water, they have those tentacles still stuck to them wherever they happen to be. Like, you want to get them off without having those nematocysts firing, right? Because that's going to lead to more symptoms. Things like, people thought, okay, well, maybe ethanol will help to get it off. Maybe we'll just like pour beer on it or something. Also not going to be super effective there. So urine ethanol will not be recommended in most cases. There's actually some products that are actually developed for this. So again, if you ever maybe work out at the beach, you may recommend this to some patients. There's actually something called Stingos that actually has this aluminum sulfate and the surfactant that's able to help kind of separate the tentacles from the skin and prevent that discharge from occurring. So you may see that occasionally. However, in a lot of cases, you don't have that available. Again, these are people that maybe they go to the beach one time a year and that's that, or they're visiting from somewhere else, maybe they're more landlocked. A lot of cases just use seawater, right? Because that's where the animal came from. So just use the seawater where it's naturally meant to not be discharging all the time, and use that. So if you can get a bucket or something, and that will help to kind of separate it off. Usually we use something like a credit card as well, and that can help to kind of use as like almost like a spatula to help kind of pull and separate that from the skin, right? So any kind of lubricant, usually like a Visa, MasterCard, someone's got a credit card on them, typically you can help to get that off. Again, seawater is always going to be a little bit better, mainly because, again, that's what the natural tentacles are meant to be floating around in normally. Now, if you didn't have that available, you could use things like, like water-soluble lubricants. You can use like things like KY or something like that. If you're in the ER, you'll typically have some sort of lubricant available. That can help to get those off as well. Now, as far as anti-venom goes, we do have one for the box jellyfish, but where do you think we normally would find that? Over in Australia. So we typically would not have access to this here over in the U.S. So if you did have something like a box jellyfish, someone who had a sudden syncope in the water or something like that wasn't related back to some obvious medical cause, we wouldn't really have anything to treat that patient with. It all have to be kind of supportive care. Because you don't need to memorize the dosing by any means, but it's one of those things where, if a patient's developing arrhythmia, respiratory depression, those are all be pretty good indications. We'd end up using it there. And actually, there's some cases where using things like verapamil and magnesium have actually been shown to be somewhat effective in helping to kind of manage the cardiovascular effects there. So you may see that being used occasionally. Okay, so any questions on that, on the jellyfish? Okay, so moving on, there's also have some stinging fish that are going to be a potential cause for envenomations here. And again, you might think, some of these are going to be found in the water. Where also do you think some people might get stung? Yeah, and aquariums and things like that. So people who have like home aquariums, they may potentially get stung if they're dealing, especially with some of these like lionfish and things like that. People like to look at them. They're usually kept a lot of those kind of saltwater sort of aquariums, and so you may see that occasionally. There's lots of different varieties here, and even things like the stingray will kind of fall into this category as well. The main problem you're going to see with a lot of these is just really the mechanical actual penetration of these spines and things through the skin. So wound care is going to be one of the biggest things you're dealing with here. However, to kind of add insult to injury, no pun intended, they're also injecting some venom into those wounds as well, and so you're going to find that that's something you have to be taken care of, and we'll talk about kind of ways to manage that in a second here. Again, anyone know any celebrity deaths related to some of these? Steve Irwin, just R.I.P. But never thought it'd be a stingray that would take him out, right? Like you thought it'd be like a lion or a crocodile or something like that. No, just simple stingray. So again, more dangerous than you may know, depending especially on the size of it. But anyway, so again, lots of different things like stonefish, scorpionfish, all have these spines on them that are meant to be sort of self-defense for the fish. However, if you have a handlers or if you step on them, things like that, you're more likely to get some of these envenomations to occur. So again, stingrays typically they end up getting stepped on, and so that's why if you ever seen like a stingray barb go out, so typically you step on them, they actually kind of fly back up from the tail and kind of go forward. So that's why you see a lot of things that happen there. So again, where do you think a lot of the injuries occur? Usually to the lower limb, usually to around the ankles, the feet. Usually we're going to see a lot of these things actually occur there. And then with the spiny fish, if there's like fishermen, collectors, typically those would be the type of people you're going to see getting envenomated there. Usually found around the Keys and the Gulf sort of area, you'll find them a little bit more commonly there. And we see a lot of lionfish calls. That typically tends to be the more common one. Again, usually a lot of that goes back to like aquariums and handlers in those cases. So, kind of interesting. So you're going to find that, with like stingrays, are going to be releasing all sorts of different components within their venom. So they're going to have things like serotonin in their amino acids and like things like phosphodiesterase will actually be present there. And so what you're going to find, it causes a lot of vasoconstriction. You're going to find it's going to cause bradycardia. And again, you can kind of imagine, like, in addition to the actual mechanical injury, something like Steve Irwin experienced, like there's also this on top of it where you can see things like cardiovascular collapse and death associated with these. Again, not super common. More often than not, you're going to find a lot of pain and kind of local vasoconstriction at the site of injury, but you can still see some systemic effects, again, depending on the size of the patient, etc. Looking at the scorpandiae, which are going to be like your lionfish and scorpionfish and things like that, they tend to have several different spines, all of which can release several different types of toxins. You have things like Stonus toxin that actually will form these kind of hydrophilic pores and membranes. Can lead to things like hemolysis and hypotension, edema developing here. So again, much more severe than you might expect just looking at a fish typically. We have things like verrucotoxin, which is going to be blocking cardiac calcium channels. What do you think you may see there? Arrhythmia, potentially arrhythmia is developing from that. And then also there's this TLY toxin here, so this trecnylsin toxin that actually increases catecholamine release and also a lot of calcium release. You can see a lot of muscle contractions, spasming, hypertension, tachycardia seen with that. So again, lots of different like systemic effects you may not necessarily expect to see just based off a simple sort of fish sting. Okay, so we mentioned, with the stingray usually stepping on is what causes that reflex for that barb to come out and sting the patient. See some, a lot of local edema, maybe some cyanosis around due to that vasoconstriction that's happening there, and then eventually some necrosis and ulceration. You're gonna find for a lot of these, one of the best things you can do is submerge the affected limb into hot water. We're gonna see why that is in a second, but again, a lot of this can help to denature a lot of those proteins that are causing a lot of that damage. So we're going to see that's one of the big things as far as first aid goes for these patients. If a lot of that stuff gets more systemic, which again, the stinger is going to help you out because it's causing a lot of vasoconstriction, which can help to prevent a lot of that from getting more systemic. But you can see things like headaches, seizures, fasciculations, and dysrhythmias can be potentially problematic there. And then looking at the stonefish, they tend to be much more rapid in their causing a lot of cyanosis and edema around the site of injury, and the wound healing is usually pretty slow. Then you're more likely to see more kind of systemic manifestations of things like hypertension, abdominal pain. Rarely may see seizures, but occasionally that can occur there as well. Okay, so typically when you're doing, if you have a management for this, you do want to get an x-ray of the site because, again, you want to look for any spines or anything that may have broken off because that could be further cause for injury, potentially for like infection, things like that. So if you can get an x-ray, see if there's any foreign material and pull that out. And then in some cases, you may actually find stingray wounds are damaging enough that they may actually require some surgery. Rare again, but you can see it occasionally. I would probably go ahead and update their tetanus prophylaxis, especially if they didn't know. Otherwise, it's how often? Every 10 years, yep. And then again, hot water is going to be good here as well. Again, submerging the affected limb in hot water can help to denature those proteins. So again, probably as hot as the patient can tolerate it. You don't want to burn them necessarily, but hot enough where it can help to start to break down some of those proteins can be very useful. And then just give something for kind of local and systemic analgesia. So if you need to give them some Ativan or something to kind of help with any kind of like muscle spasming, if you need to give them some opioids, that is all pretty stock for these guys. There's one antivenom available for stonefish, and again, this is one of those things we're going to find much more likely in Australia. We don't really use it here all too frequently, but just know there is one available for those patients. All right. So any questions on any of the tox stuff? All right. So again, just know kind of like what these sort of envenomations may look like. Presenting, because again, a lot of times you may not know. So again, if say a patient shows up to the ER and they say, I got bit by a snake, and you're like, what did it look like? I didn't see it. And, they have 2 little fang marks, and you're starting to see there's really a little bit of kind of minor, irritation at the site, but they're starting to complain of paresthesias. What might you think? Something like a coral snake, right? So again, that would be much more likely to be a neurotoxin than you would see. And again, I'd probably make it more obvious. Like, patients got, ptosis and they're, starting to slur their speech. Their alcohol is negative. What could this be? You think something like, a neurotoxic sort of snake versus they came in, the limb was, swollen up very quickly and they had a lot of area of ecchymosis and their fibrinogen comes back in the tank and platelets are low. You probably think more like a rattlesnake or like a water moccasin or some sort of pit viper, right? So again, it's good to kind of understand those delineations. That way when someone says, hey, I got bit by a snake, you can kind of look at it and evaluate what it could have been, because a lot of times we may not have positive identification. We just go off the signs and symptoms that they're presenting with, right? Or if I say, hey, here's a patient comes in, EMS found them down, here's their signs and symptoms, here's their vital signs, what sort of toxidrome are they experiencing, you can be able to identify that, whether it's like an anticholinergic versus a sympathomimetic. These are sort of things you want to be able to identify, because again, your history is oftentimes going to be pretty poor with these patients, and so you may not have the full story. You kind of have to go off of what you're seeing there, right? Treating the patient, not necessarily the numbers or what you kind of hear from EMS or something like that. And is there any good resources? So say you had a patient that showed up to your ER, no history whatsoever. Is there any good ways you think you could try to identify what maybe medications they happen to be on, what's on their medication list? How'd you do that? So a lot of these patients tend to be on opioids or some other sort of narcotic, and where can I find out if patients have been on narcotics? Yeah, go to that E4. It's actually very handy because, again, I may be looking for that, but there's lots of other drugs. They're on blood pressure medication or they're on antidepressants. I can find out where they're filling their stuff at, and I can call those pharmacies and try to figure out what other medications they might be on. They're very, very helpful and that sort of thing, because they've spent many a time calling the local pharmacies and saying, hey, I have this patient here. What other medications might they be on? And of course, you have to provide identification for the patient, all that good stuff, but they'll give you the information pretty freely, which is very helpful in a lot of cases. The other big thing is, looking at their medication list, try to see what other medications might be available in the home as well. So especially if you're dealing with a kid who, especially teenagers, they're getting into stuff they shouldn't be. Ask like, okay, well, what other medications are in the house? Like, is mom and dad on anything, or siblings on anything? Because that could also be kind of clouding the picture there as well. The other big thing is like, with calling the pharmacies, back to that point, CVS's, they all talk to each other. Walgreens, they all talk to each other. Publix's all talk to each other. So even if you don't call the right pharmacy they fill most of their stuff at, they can at least look at their records from other stores and figure out what they filled in the past, which can be very useful. Yes, ma'am. So usually, or at least not usually necessary, but like in some cases, you have the parents that are there as well, right? And so that sometimes is a conversation you have to have with them and say, hey, I know this is what it looks like the patient may have gotten into, but like, what else is in the house? And the parents are like, well, why do you need to know what medications I'm taking? And certainly you can be like, well, listen, like this kid was suicidal. I have no idea what he's capable of and what he might have gotten himself into. Like, what other medications are available to them? Or in cases, if you do like little kids, for instance, I had this one infant that came in, I probably mentioned this before, but infant came in, looked like an opioid overdose, but there's no opioids in the house. Parents are vehemently denying there's any opioids anywhere. But the dad's, I was like, well, what do you want, Dad? Like, what do you want, Mom? And he said, well, I'm on a clonidine patch for my blood pressure. And so I was like, okay, well, this actually looks a lot like a clonidine exposure. And there's like, well, there's no way this kid could have got the patch. And then it ended up, a couple of days later, kid ended up pooping out a patch. And so again, when you have siblings that are in the home, a toddler will go up and try to feed it to them and things like that. And so little things like that, you have to kind of play detective in a lot of cases and try to see what kind of clues you can piece out to say, well, what could this be? Because again, an infant's not going to tell me what they got into, right? At least, I don't know. Not too many infants that can talk. I've seen Boss Baby, but that's probably the kind of the extent. It's probably more the exception than the rule, right? Okay, so any other questions on tox stuff? All right, fantastic.